Namaste, Sadhna.
Good evening. Thank you everyone for being here with us today. I, Ankit Dogra, with my teammates Dr. Deepika Chhabra and Mr. Amit Saxena from Medical Services, Jagsonpal Pharmaceuticals Ltd, and Mr. Shahab Makrani, Area Sales Manager from Naari Division, welcome you all to today's scientific sangam on a very pertinent topic, once a cesarean, always a cesarean. We thank the office bearers of ISOPARB Prayagraj and Obs&Gynae societies of Kanpur and Jaunpur for associating with Jagsonpal for this webinar. We also thank ICOG for granting 2 ICOG credit points to all the attending doctors. Naari division of Jagsonpal Pharmaceuticals Ltd presents to you PRORETRO 10 mg tablets of indigenously manufactured affordable micronized dydrogesterone for luteal phase support in ART, IUI, and for recurrent pregnancy loss. Other quality products include Cystelia M tablets formulated with the ideal 40:1 ratio of myo-inositol and D-chiro-inositol with L-methyl folate and vitamin D3 to restore reproductive health in women, and Endoreg 2 mg tablets of Dynogest for the medical management of endometriosis and endometriosis associated pelvic pain. A warm welcome to all the esteemed faculty and attendees. Dear attendees, please post your queries and suggestions in the Q&A box to be answered at the end. Please note this webinar is streaming live on the Facebook and the link is provided in the chat box. Kindly share the link in your professional groups as well to ensure maximum reach for this academic program. For future reference, please visit our YouTube channel, Jagsonpal Medical Insights, for the complete recording. Now, we welcome and request the organizing chairperson of the program, Dr. Ranjana Khanna ma'am, founder, president, ISOPARB Prayagraj, to kindly take the proceedings further. Over to you, ma'am.
A very good evening. Friends, it's a pleasure to host this webinar because I think this is one topic which all of us, are doing in our practice and we see in abundance. So first of all, before we start the program, as always, as is the tradition of ISOPARB Prayagraj, we'll begin with Mahamrityunjay Mantra. So to begin the program, I would like to invite our chief guest today, that is Dr. Anuradha Khanna. She is indeed a very dear friend of mine, and she has been the head of the department of BHU, Obs and Gynae department, for so many years. And currently she is also president-elect of UPCOG. So she's been ex-HOD, ex-president of Varanasi Obs and Gynae Society, president SFM UP chapter, president Varanasi Menopause Society, and president-elect, that's I've already told you, organizing secretary UPCOG 2009 and organizing secretary AICOG 2012. Scientific chairperson, zonal IMS Con, organizing chairperson, UPCOG 2019, organizing chairperson, IMS Con 2021. We were witness to that. It was a very grand show. GCM of IMS, MD, MBBS examiner, and she's got so many papers, so many awards. And what to say, she is very well known. And though she did not actually need an introduction, but I felt it is my duty to introduce her. And she is Indo-Hungarian Fellowship Awardee and Indo-Netherlands Fellowship Awardee. Best Paper Awardee, several chapters in books. And if you tell her to speak on any subject, believe me, she goes to the depth of that. So I would request you, Dr. Anuradha Khanna, ma'am, please give us some words of blessing before we start this program.
Thank you very much, Dr. Ranjana Khanna, a beloved friend of mine. I am thankful from core of my heart. And as you have just listened the shlok of Shivji, the Mahamrityunjay Jap, so lots of blessings to all of you from Lord Shiva, from Vishwanath Temple, from Corridor, from Varanasi. And really, I appreciate you all, you, Dr. Amita, Dr. Jaunpur Society, and also the Kanpur Society, Dr. Amber. You all are very close to my heart. And this topic which you have chosen today, the Caesarean section, is a topic of controversy since it is born. The Caesarean word is born, and there are so many things in it. You have very well chosen the indications, the contraindications, the VBAC, the suturing. And one thing more I would like to say, we have to discuss also, I think Dr. Ranjana, you will be covering in VBAC, the stuck situations in Caesarean section. Because many of the times we got stuck starting from the anesthesia to the abdominal opening, to the sticking in the opening the uterine cavity, the extensions, the bladder, the bowel, what not. So I had one talk given long back in Nashi, in
There's going to be a
Lucknow.
part 2. There's going to be a part 2.
Yeah. So that is also very nice. Now, with all my best wishes to all of you, especially Ranjana, Amita, and Kanpur Society, Jaunpur Society, Allahabad Society, one thing is more, on behalf of Dr. Sulekha Pandey, the ISOPARB National Conference is here in Varanasi, and Dr. Samant is also, I think she must be listening or she will be there. So you are all requested to come in Varanasi, which is in 6, 7, 8 May. So that it will be a very auspicious moment for all of us, and also very, very good academic fees. So all of you have been invited. So thanks a lot, Dr. Ranjana, Amrita, and all of you for inviting me. Thank you very much.
Thank you so much, ma'am. And I hope you'll stay on now, because we will keep on asking you for your opinions also.
Definitely, I will.
So now I would request Dr. Amita Tripathi to take over the sessions.
Thank you, Ranjana ma'am. Good evening and a very warm.
There are going to be 3 conveners. It's going to be Dr. Amita Tripathi, who is the Honorary Secretary, ISOPARB Prayagraj. And there is going to be Dr. Amber. She is the Secretary of Jaunpur Society. And Dr. Parul Khanna, who is the communicator of ISOPARB Prayagraj. So please, go ahead.
Thank you, Ranjana ma'am. Good evening and a very warm welcome from my side to all the faculty and delegates also. Thank you, Jaunpur and Kanpur OBGYN Society, for holding our hands. And so without wasting any time, we'd like to start the first session. And the topic is how to prevent primary cesarean section. And we have one of the best suited person for this topic, very well respected Dr. Jayam Kanan ma'am. And to chair the session, we have with us Dr. Meena Samant ma'am. She is a senior consultant in HOD, Khoji Holy Family Hospital, Patna, Chairperson, FOGSI Clinical Research Committee. Her tenure as a Secretary General ISOPARB have been exemplary. She has been Vice President, Patna OBGYN Society. She is recipient of prestigious Kamnira Oration, and she is a DNB teacher. Welcome, ma'am. And our next chairperson is Dr. Shubha Singh, President, Jaunpur OBGYN Society. She is one of the first practicing gynecologists of city of Jaunpur, and her center in Jaunpur is known for intensive care of complicated antenatal cases, VOH and fertility management. And one thing I would like to say is she has contested for UP state elections, and she is director of 2 nursing homes and a diagnostic center in Jaunpur. Welcome, ma'am. With this, I request Dr. Shubha Singh to kindly introduce the topic and the speaker for the today, Dr. Jayam Kanan. Dr. Shubha Singh, please.
Yes. It is my pleasure to introduce Dr. Jayam Kanan in front of us. She's FOGSI Adolescent Health Committee 2013 to 15 Best Committee Awardee. She's Professor of Tamil Nadu MGR Medical University. She's Managing Trustee Garbha Raksha Group of Institutions. She's Director of GFC Fertility Center, Trichy and Chennai. And she's Vice President FOGSI 2018. She's President of Free Legal and Center for Women Trichy since 1992. She's a member of PMNCH WHO since 2008. She's course director, she's certificate course in reproductive medicine FOGSI since 2012. And her major achievements are President of India Medal for Outstanding Performance in MBBS, 13 medals and prizes in MBBS, state first in MBBS, university first in MD, and best paper awards 4 times. Best book in medicine award 2 times from Government of Tamil Nadu, and Durusha S.N. Pandit Award FOGSI Community Work Best Committee Chairperson. Lifetime Achievement Awards are IMA, Tamil Nadu MGR Medical University, Trichy Women Association, Tirumular Society of Siddhas, Academy of Clinical Embryologists, Best Society President Award since 2013 FOGSI. And publication, she's published books in medicine in 5 books in regional language and 1 in English, and RCAG award, that is a prestige that is Distinguished Service Medal 2018, first Indian to receive this award. So the topic, as we have discussed, it's a burning topic amongst gynecologists, obstetricians, and the society. Once a lady conceives, this question goes on clicking the lady as well as the family from the very beginning. What will she land up, whether there'll be normal delivery or cesarean? So now I request ma'am to have her words on this topic, please.
Thank you very much, my dear Shubha Singh and Meena Sampath, for chairing this session of mine, youngsters with this elderly person. But Jaunpur is known to me also, because a couple of years ago, I came for the National Monitoring Inspection Committee of Ultrasound Centers in Jaunpur. I traveled down all the way, going up to the airport, which is there in Lucknow, and come down to Jaunpur. And then from there, I traveled to Varanasi and then returned back to Tamil Nadu. So I didn't know that Jaunpur is such an interior place, but the ultrasound work which was done in those obstetrician gynecology oriented centers were too good, except one center in which we found some problems. That was also not a thing which was alarming. It was just some omissions, not commissions, as to which the PCP&DT Act was meant for. And I really bless the would-be chairpersons of FOGSI, Anita Rajoria, Kanjan Sharma, Kiran Pandey, and Rekha Rajendra Kumar, who are working tirelessly hard to occupy the chairs in FOGSI. Now, becoming a FOGSI executive is also a burning problem. So also this volcano problem of primary Caesarean section, which is very much talked by everybody. If you say that you are a gynecologist and sit by the side of a person in a train, he will immediately ask you, why are you doing so many Caesarean sections?
That is the first question. The next question he asks is, why are you having so many fertility centers? I am really tired of this question. I am answering. Then I go and ask them, why are you having so many real estates which are coming up? Why are you having so many beauty centers coming up? So answer me that, I will answer this. This is how I go with these people. Now, Uttar Pradesh is not very bad. Couple of days ago, the 31-12, the sex ratio was brought out by the NHS 5, National Family Health Survey. You see, you are the person with 1:1 ratio. You are not a person with burning the female child. Only few states are burning on the, this is more on the western side, little on the eastern side, and you are on par with everybody. Uttar Pradesh, even though it's the largest one, it has got a really little less educational group, but still you are keeping up your female sex ratio very nicely. Same way, NHS 4, when it came with the Caesarean rate, you see you are in the pink area. You are in the yellow area. You are in the red area, meaning that you are below 14% Caesarean section. You see, I am coming from an area which is in the darker shade. That is, we are doing more Caesarean sections. And little on the West Bengal also is there. Now, why doctors are doing more Caesarean section? It's a very common thing that you find out, especially in private, because the doctor is greedy. She wants more money. She has just not built a big 6-story nursing home, you know. She has to pay the money. So that is why she is converting every normal delivery into Caesarean. So what I did is, I kept the same fees for Caesarean and vaginal delivery, so that that question is not put to me. That was the first way which I say that I have prevented people from thinking that I am doing Caesarean section because of not the regular indicated one and an unindicated one. It is private, it is okay. What about public? Is public also doing more Caesarean section, which we are seeing more? Yes. 2015, as more of extending the services to the rural areas, the government started putting up more operation theatres in the primary health centers, and Vellore district Manavaram primary health center is the first center to start Caesarean section. And today in that center, 53% of deliveries are C-sections compared to 18 to 20% Caesarean section of the patients referred to the other centers from the primary health center. So primary health center also given a chance are doing Caesarean sections. But the question is, are they indicated or not indicated? Can they be prevented, not prevented, is our topic of burning today. You see the changing scenario. From 1990, in 15 years, we moved from 3 to 10. But now we have moved to 32% all India average. And this mainly because government has come out with so many schemes for Caesarean sections. Wealthiest are also preferring Caesarean section because they can spend little time, come on in the morning to the hospital, 6 o'clock, 7 o'clock deliver, next day morning can go home back and sit on the computer and work on it. Then the changing diet habits. You know well, Caesarean section rate is 9 to 10% in below, they're saying 23 BMI, and it goes to 30% when the BMI is 40. That is another thing. Late pregnancies. No, I don't want labor pain. Let me go through Caesarean section. And these things are the more things added to it is Caesarean section on demand. The day, the date, that hour, the minute. Luckily, it has not come into the seconds. So we have not entered in the sports field, but we are in the minutes field, and it is 10. We all should remember 12/12/2012. One hospital has done 108 Caesarean from morning 12:05 to 7 a.m. in the eastern side of India. That is one. Even this year, 22/2/22 was another landmark month in which more Caesareans were done. So we also have some acceptance to the public demands also. Then it came in 2018 that the Caesarean section rate is maximum in Telangana. Everybody knows well. Is that so? Now you look at it, Telangana is overtaken by West Bengal. Telangana is now 81 in the urban, 74 in the rural, and this you look at West Bengal is few more percentage of cases being done. So we have doubled our cesareans in the last 10 years, and we are really accepting that we have gone into an epidemic as it has been released by NHS 5 data 4 days on March 26, 2022. So 84% of West Bengal private rural facilities are caesarean sections. So everybody asking the question, this apt topic by Ranjana Khanna, preventing the primary cesarean section is very, very important, just because 3 days ago we have been pulled up very badly by the National Family Health Survey also. Rural India is not spared. It also has got high rate. Rural India, private, rural India, this thing also, public also the same rate. So there is no difference between the government sector and the private sector. It is only statistically insignificant difference we see. So our topic is preventing the primary cesarean section. Is it because it's a social angle only? No, it has got also our obstetric angle. Look at this. We have quadrupled the incidence of placenta accreta from 1980, which was 1 in 1,300 something. Now we are 1 in 272. This placenta accreta is the one which is making us feel so dready. And also naturally the cesarean hysterectomies and the dreaded obstetric complication now no obstetrician want to look at is a placenta accreta. If I have an enemy obstetrician in my city, I will immediately say, she's a good doctor, you go to that doctor. I will send the placenta accreta to her only. That is how we all feel it's a nightmare. So if we want to prevent all these things, can be obstetrician, we do have a control, yes. If you do a cesarean for the indicated one, like previous cesarean, cord prolapse, genital herpes, this thing, labor arrest, this is where the point stresses, the placenta previous, accidental hemorrhage, it's all those things stand reason to avoid primary prevention. So also there are options indication 1 and 2A or the one which are well noted down, and we should not just take it that yes, it is given option spontaneously can do cesarean section. Today, and nulliparous in the this thing about 37 weeks when we have to do is also one that has to be looked into. And one of the hospitals in Telangana which does a good vaginal delivery has come out with the data. Even February 22, they have come out with the data which can answer Dr. Anuradha Khanna's question of vaginal birth after cesarean section. They have put down 35 cases of previous cesarean for vaginal birth, in which they succeeded in 22 cases, and they have vaginal birth after C-section, 65%. Those who want to be back data and how to proceed to look at that Fernandez Hospital data. This hospital says they had 24% of the cases were option 1 classification. Out of 10 classification, 1 itself takes so much. We see in that the presumed fetal compromise. What is this presumption is the question which we have to answer to prevent primary cesarean. They also had cesarean section on maternal request also. Probably because it's a February month, 22 to 22 would have stood up for them also. Right. So how to prevent? Point number 1 is avoid emergency cesarean section. What is emergency? Cesarean defined as non-progress of labor, suboptimal CTG. What is meant by non-progress? How many hours? Nobody has defined. Suboptimal, yes, we have got category 2 and 3 which are suboptimal, but still there are ways to get over with the 2, which is the most common finding that is given. And all these things, madam, I am sitting in a place from Jaunpur about 30 kilometers. You said you found it difficult to come to Jaunpur. I am 30 kilometers away from there. I am a single doctor. So I have such a big practice. I have so many patients in the OP. I don't have time to look at my patient. And I am used to induction of labor. I am used to diagnose arrest. And if I find fetal problems in utero. After delivery, I found them having respiratory distress. So all these things do not work for me is one thing that somebody can say. Yes, the obstetrician, the center, the nurses, and the patients, all of us contribute to this point number one. And we know well that sometimes Khanna, the Doppler gives us some complication results, which can be sometimes fake also. And they immediately recommended C-section. The patient runs up to us with that report, and if we don't do the cesarean section and something happens to the baby, we are put to task. By this, we are doing about 3.5 million preterm deliveries in India, which is the most, they say, largest preterm deliveries in the world. And WHO says, if you do a 10% rise in cesarean section, you are out with your maternal neonatal mortality and morbidity. Yes, right. But for whom? It is meant for the people who have delayed marriage, late conception. Let ART people take all those things. Let not common people like this who are dealing with conceptions in the spontaneous way take it, because 1 in 1,000 may be going in for ART in India, which may be even to 1 in lakh in places like Jaunpur. Kanpur may be more, Jaunpur may be less. One hospital at Delhi did a work. They beautifully came out with a suggestion. Stop doing a single doctor practice. 4 or 5 obstetricians joined together. Still, you work few hours a day, but your patient gets a maximum support because you can attend 4 hospitals, 4 into 6 hours. At the same time, you'll have more patients. In your absence, the other equally trained expertise will be looking after your patients. Good suggestion. They brought out from 78% to 18%. So other suggestion which was given was, if you are well established in practice, practice in only one center. Have good maternity trained nurses, do a good counseling. That also will help. This is what this hospital brought out in 2017. Probably people can think over and do a group practice also and keep a good company as we have in this ISOPARB and other FOGSI societies. Okay, after all these burning problems, looking at all those things, Arul Kumaranan group came out saying it is no good. 2018, they came out saying that please have a structured second opinion. Do not accept any non-clinical interventions. Conduct more workshops. We have more evidence-based guidelines like Lakshya, Manyata, and other things. That is what they say. The point number 2, which I have to bring it, they took back the partogram and they brought back the labor care guide. So that means we are nowhere going with the time of this first stage of labor, second stage of labor. We are going with more of the patient-oriented reports. So with this, what happened? No Friedman. 2010, this thing, take it up, that one. No 4 centimeters as a beginning of partogram, 5 to 6 centimeters. If patient has got good contractions, not 4 hours, from 4 o'clock you do a PV and then 8 o'clock you do a PV. No, you can do the PV at 10 o'clock itself because patient has got a good contraction. And this thing, if you see, if you are putting a CTG and you are finding the contractions are very heavy, don't bother so far as the baby and mother are okay. Because Friedman work was between the age group of 20 and 30, but now we are also seeing more patients above the age of 30 also. The point number 3 which came out was oxytocin usage. Oxytocin for acceleration of labor, oxytocin for induction of labor. If you are using it for acceleration of labor, kindly use it for extended period. If you are inducing labor, should you induce? Think twice before starting the induction of labor, because induction of labor invites more cesarean sections, and by doing a cesarean or by prolonging the induction, there is no difference of either the maternal or fetal outcome. So induction should be thought twice before it is done unnecessarily in patients. Indicated is a different one. Can I prolong the drip care having started the drip? Yes. Earlier it used to be 12 hours, now it can be 24 hours. And they have found every 4 hours of addition can produce nearly 38% more vaginal delivery. Just because the patient has got a slow progress with your drip kindly do not terminate the trip and go for cesarean section. Kindly do not think by your pervaginal examination, which is done once in 2 hours, even then, chorioamnionitis is not setting in so much, it has not been proved. Point number 4 on which we can prevent cesarean section is the second stage of labor. If you are used to giving epidurals, please give it a little late after 6 centimeters. And if you are having a second stage, which is more than 3 hours, please accept. More than 2 hours in multi also, please accept. If it is epidural, please go beyond 4 hours. My daughter-in-law who delivered at America, she had a head seen at 6 a.m. in the morning. At last, her baby was 3.8 kg and she had a cesarean at 1 o'clock in the afternoon. That means they have waited for 7 hours after the second stage of labor in epidural. Okay, so this is one standing example which I have. Please do it up like that. So the next one is CTG abnormality. You know, well, tracing 1 is okay. Tracing 2 is the one which is controversial. Tracing 3 is the one in which we have to take it up for cesarean section. So in the tracing 2, point number 5, can we prevent cesarean? Yes. Change the position of the patient, can do a little scalp stimulation of the baby, and there are people who advise amnio infusion also. I'm not used to it, so I don't talk about it also. Then the next one is hypertonic uterine inertia, uterine tachycystole. Sometimes when you start oxytocin drip, this is another problem which comes, in which case we need not rush to cesarean section, stop the drip, give some beta mimetics and see that she settles down, and continue with a reduced dosage of drip. We can be better, and this can also be shown. So if you want to prevent primary cesarean section, go for oxytocin 24 hours in regular cases. Even if there is rupture of membranes, you can consider oxytocin for 18 hours. Electronic fetal monitoring only in high-risk cases. Consider 6 centimeters as active labor. Second stage of labor, 3 hours. Correct all malrotations even in the antenatal period in the last trimester. Kindly stop the diagnosis of failure to progress using the Friedman's curve. Care provider, that is what Arul Kumar said. Now, we should not have just a doula who's just sit with the patient. She should be an expert, well-oriented doula who should be there. So the bottom line which has been done is normal labor length, no more, obsolete. Care provider role, better enlarged. Adopt new guidelines. Failure to progress should not be the word written in the cesarean section. No more 4 centimeters. Please do not admit the patient before 6 centimeters at all. Probably keep her walking between 4 and 6 centimeters and admit her only at 6 centimeters. So allow the patient to know that a doula should be a person who can support her well, and she will not be done any unnecessary interventions. Epidural will not be given unnecessarily on demand by her, and she will have only intermittent monitoring. Now, hey, doctor, you are coming lately to see me. Yes, that is how, otherwise I'll be doing more cesarean. That is what we have to tell the patients. Risks of this thing, cesarean is also there, more of thromboembolism, higher casualties, higher risk of placental issues and rupture uterus in the subsequent pregnancies, which one has to understand very clearly. Uttar Pradesh, again I am coming back with a congratulation with the 26/2/22 report. You have increased the first trimester checkups. You have increased the WHO determined 4 antenatal checkups, but only thing is you have gone by cesarean section from 9.5 to 15, which may be brought down. Private deliveries, private LSCS and obesity all remain the same. There's no difference in the last 6 years. And highest cesarean section rate is only in our part of the country, not in your part, even in the last report. And points to ponder, again I say, do not have non-indicated cesarean section, do not denote failed induction, accept the time frame which is given for the first stage, second stage, and no time frame, make only individual patient size time frame, always have a trained staff. Second opinion is a must. Peer review of your own work will help you better. labor care guide is to be replaced with partogram. So set up more vaginal delivery trays rather than cesarean trays in the theatre. So let us reduce and revert back to our 1992 status of cesarean section. At the same time, reduce the MMR also. So let God give all us this better support by preventing this cesarean section. Thank you very much for patient here.
Thank you, Jayam, madam, for that.
Oh, Dr. Jayam, it was an excellent talk.
Thank you.
Dr. Meena, please go ahead.
Yeah. Thank you, ma'am, for that wonderful talk. And you've beautifully highlighted all the things, when, like even offhand, when we hear lay people talking how doctors are greedy, and even amongst our own selves, we tend to get a little defensive that we are doing right. How dare you point out to us? But madam, you've really put out how we need to introspect ourselves. Each and every point, there's a lot of scope for us to bring down a cesarean rate. At the same time, keeping both the MMR and the perinatal outcome good, reducing the mortality at both the ends. Peer review, I think, is so important. Like we keep saying, we also talk of not only litigation, but patient request or patient's request. Another thing is, many a time, even we know, we may not like to, say it publicly, but there are many which we would say is doctor indicated or doctor request, because they sort of, during the counseling, they counsel in a way that patient would sort of take it that, yeah, that's the way to go. So there again, I think we as doctors need to do a lot of introspection. So many new things have come up in these last few years because of the growing concern how the long-term impact of rising cesarean section is having in the lives of our women. So, looking at every indication of induction, having a relook, doing a peer review. And I think, when we, especially somebody, I think, who pointed out that it's a younger doctors who are, really, charged up to do so many cesareans. I did this. I remember during my early days, today in my emergency duty, I did 8, I did 5. So it's kind of, a feel good factor also. So I think now it should be reversed. Rather feel good. I was able to do so many vaginal deliveries because that is turning out to be a lost art.
Exactly.
Yeah, the dollar support and also a constant, like the CME that Madam Khanna and Dr. Amita, the whole team, they've, designed for today. Things like this that will, bringing us, sort of giving us the courage to, yes, avoid cesareans, especially, there are many, like the date you told us, that happens. And I think we all can, it is kind of policing ourselves, because no doctor would like to be policed by somebody else.
Yes.
So the labor care guide and everything, 6 centimeters is so important, and the time duration doesn't really matter, but it's the individual patient monitoring that matters. So ma'am, that was excellent. Thank you. And yes, my friends, my colleagues from across India who are there, they are into elections, like ma'am said, my best wishes to all of you. And Madam Jayam Kanan, she's so passionate about teaching and coming. I remember she'd come to Patna and she'd taken train, then flight, and likewise she went to Jaunpur. I passed Jaunpur so many times traveling from Patna to Lucknow and so on. But I think, like ma'am, we should also, I think Jaunpur is not that far from here.
Yeah, and I really thought that nobody better than Dr. Jayam to take up this topic. And I was very right. Thank you so much.
Excellent coverage, Jayam.
Credit goes to
Dr. Meena
for releasing this latest National Family Health Survey 3 days ago. That is on Saturday. They released, I immediately caught that UNICEF of Amit and caught that paper from him. From there I saw, yes, They stand very nice, so I can praise them very nicely also.
Uh,
Amita,
So much of
there
effort.
is,
Why
Amita,
not deserve that comment?
thank you so much, ma'am. There is one question in the chat box.
I
If there is
think-
any role of,
Acha.
if
Okay.
there is any role of pelvic assessment at term.
Yes. I didn't talk about it because there are other people who are going to talk
Yeah,
about
the
it.
next
So
speaker
that
is going
is
to
why
talk about it.
I did not want to intrude into
Yeah.
others' topic.
Yeah,
So in
yeah.
the next topic, they will be clearing.
Exactly.
Okay.
Dr. Jayam,
Thank you.
may I say something?
Yes.
Yes, Anuradha.
Dr. Jayam, it's a pleasure to see you and listen you. You
Yeah,
are
yeah.
really an awesome person. Awesome in all aspects. I really love
Thank
you.
you.
And
Thank you.
all the slides were so original. Just as if you are thinking and writing, thinking and writing.
Yes.
So beautiful. One thing I will say, the art of labor is going off.
Yes.
No one is
Yes.
thinking what at our when we were resident, then we have to imagine, okay, this is the presentation, this will be the rotation of it, this will be the shoulder rotation, this will be the descent. Now, by a paperless partogram, we were imagining that now the patient will deliver. Once my resident used to phone, madam, this is the finding. And we used to say, okay, wait for another 4 hours, wait for another 6 hours. And we don't go on doing all time pervaginal examination. But now I see every doctor is very much medical legal oriented also
Yes.
afraid of it. That is the
Correct.
biggest cause of the cesarean section, not the money. Doctor is
Yes.
not for the money, but she is so much scared, so much litigation
Yes.
from
The bad
inside
man.
the optician. From the inside, okay, अच्छा कोरियोनाइटिस था तब भी उन्होंने वेट किया क्यों नहीं सीजर
Right.
कर
Right.
Correct.
Right. There for each and every.
Dr. Anuradha, you are very right. I mean, the doctors have become more scared of medical legal than money. We are
Exactly.
being blamed for money, but not actually money. It's more of that everybody is scared.
Medical
What
legal.
will
Yes.
happen? Too much monitoring and everything is required. And that art, as Dr. Jayam has beautifully explained everything. Wish everybody, yeah, very good that youngsters follow this.
Yeah.
That
Thank
is
you.
very
Thank
important.
Thank you.
Thank
That
you.
is very, very important.
Thank you, Jay ma'am and the chairpersons for excellent inputs. Let's start with this next session that is on indications and contraindications of cesarean section. And Dr. Shaili Parush Agrawal, an alumni of our medical college, is going to speak on this. And to chair the session, we have with us Dr. Kanchan Sharma. She is a director and ERT specialist, Akash and Fertility Center at Kanpur. She is secretary, Kanpur OBGYN Society, president of IHRF Kanpur, and she is recipient of various awards like Pratigya Social Impact Award, Naari Ratan Samman Award, Corona Warrior Samman Award, and she has organized many various conferences and ultrasound workshop, and she had been quiz master in WWCon, which was held at Kanpur. Welcome, ma'am. And I would like to welcome Dr. Abhilasha Kumar. She's director and consultant at Kumar Maternity Center. She's treasurer ISOPARB Prayagraj chapter, and her field of interest is in fertility and high-risk pregnancy. With this, I request Dr. Abhilasha to kindly introduce our speaker, Dr. Shaili Parush. Dr. Abhilasha.
Good evening, respected faculty and all the delegates. The topic now is indications and contraindications of cesarean section. And the speaker is Dr. Shaili Agarwal. She is Professor Obs and Gynae in GSVM Medical College, Kanpur. She is the Joint Secretary of Kanpur Obs Gynae Society. She was the convener of Basket for Beginners Workshop at AICOG 2020 Lucknow. She was the Scientific Secretary, WWCon International Conference held at Kanpur in 2018. She is the founder member of Kanpur Menopause Society and ISOPARB Kanpur. She is a core member of Safe Motherhood Committee of FOGSI from 2020 to 2023. She is a master trainer of CMONG, IV, CF, and newer contraceptives. Her interests, special areas are high-risk pregnancy, emergency obstetrics, and menopausal health. She has more than 30 national and international journal publications to her credit. She has contributed chapters in FOGSI Focus. She has been speaker in various state chapters, Yuva FOGSI and FOGSI national conferences. Welcome, Dr. Shelley, and please go ahead with your topic. Thank you.
Thank you so much, Dr. Anuradha, for such an elaborate introduction. And I'm very thankful to Amita Tripathi and Dr. Ranjana Khanna ma'am for considering my name for this wonderful panel, this wonderful symposium on cesarean section. Thank you so much. And my regards to chairpersons and Dr. Anuradha Khanna ma'am and Jayam ma'am and all the esteemed faculties present here. So topic which was allotted to me is indications and contraindications of cesarean section. Next, please. Next. We all know cesarean section is an operative procedure whereby the fetus, after the period of viability, is delivered through an incision on the abdominal wall and the uterine wall. But whereas we have seen a tremendous increase in the rate of cesarean section worldwide, it is around 21.1% if we see the whole scenario on the worldwide. But in India, it is already crossed the 20% as far as the NFHS 4. And the WHO threshold was 15%. So we are already ahead of that WHO threshold. Next, please. If we see the indication for cesarean sections, it can be divided into maternal, maternal-fetal, and fetal indications. And by seeing this chart, we can clearly say that the more maximum cesareans are done for the arrest of labor, which Jayam ma'am has considered that we should switch to labor care guide instead of partogram so that we can avoid all these cesarean sections. And secondly, it is due to the fetal distress. That is 23% are due to the non-assuring fetal heart rate tracings and 17% are due to malpresentations. Rest other are because of maternal fetal indications. It can be on the maternal request. It can be multiple gestation or preeclampsia. Next. So this is the chart which is showing all the indications of the cesarean sections. We have divided into maternal, maternal-fetal, and fetal. In the maternal indications, first and foremost is a prior cesarean delivery. Then it can be abnormal presentation. It can be on the maternal request, prior classical hysterectomy. Then there can be scar. If we do not know what was the scar type in previous pregnancy, previous cesarean, then uterine incision dehiscence, full thickness myomectomy, genital obstructive mass. It can be a huge fibroid, it can be ovarian mass, sometimes invasive cervical cancer, prior trachelectomy, prior pelvic reconstructive surgeries, cerebral aneurysm or AV malformation, which can put the patient life at jeopardy during the second stage of labor, cardiac or pulmonary disease in severe cases, and then the sometimes perimortem cesarean delivery. So these are the indications for maternal indications of LSCS. In the maternal-fetal, it can be cephalopelvic disproportion. Then it can be a failed operative vaginal delivery with a failure of forceps or failure of ventrule. Then we have to switch to the LSCS and placenta previa and abruptio placentae. For the fetal indications, first and foremost is the non-reassuring fetal heart status. Then malpresentation, be in the form of transverse lie or be in the form of breach. Then macrosomia, congenital anomalies like hydrocephalus, abnormal umbilical cord or cord prolapse, abnormal Doppler studies in which we are suspecting fetal distress, and their history of prior neonatal birth trauma during the normal vaginal delivery which happened in the past. So these are the indications which are for the cesarean delivery. Among these, there can be absolute indication in which normal vaginal delivery is not possible, and there is relative indications. For the absolute indications, previous classical cesarean section, or we are having a history of cesarean section in which the incision was extended to upper segment, like sometimes T has to be given in case of difficult delivery of the fetus. Then if there are more than 2 previous LSCS, then VBAC should not be tried. Then previous LSCS and she is having malpresentation in this pregnancy also. If she is having history of vesicovaginal fistula repair, then again it becomes an indication for doing to do cesarean section in this pregnancy also. Then extreme degree of contracted pelvis in which vaginal delivery is not possible, and central placenta previa. So these constitute the absolute indications of cesarean section. Next. Then there can be types of cesarean incisions which will be dealt in details by further speakers. So next, please. There is one thing that is lower segmental vertical incision. Sometimes we have to give, instead of transverse incision, we have to give a vertical incision, like if we are getting a constriction ring, or we are doing a preterm delivery in which the lower segment is not formed, or it is a transverse line. But the disadvantage of this type of incision is it can extend vertically up to the lowerly up to the cervix, vagina, even bladder, and anteriorly up to the upper segment. So it will become risky in the future pregnancy. Next. If we talk about the classical cesarean section, we see very rare cases of classical cesarean section nowadays, but there are some situations in which we have to do the classical cesarean sections. If we are conducting LSCS on a preterm baby and it is breech or transverse lie, or it is having non-reassuring fetal status, if the lower segment is very difficult to assess, like due to severe adhesions, due to prior surgeries, or the patient is morbidly obese, if she is having uterine abnormalities in the form of huge myoma in the lower segment, or anomalous uterus, or cervical carcinoma. And sometimes fetal indications like macrocrania, sacrococcygeal teratoma, myelocele, and conjoined twins, we have to do the classical cesarean section, but it should be noted in the file very clearly so that when she has a pregnancy in future, it should be dealt carefully. Next. Now coming to the contraindications. As such, there is no true medical contraindication for LSCS. The cesarean section is always an option, even if the patient is dead or dying, or even the fetus is dead or dying. But if we talk about the ethically, a cesarean section is contraindicated if the pregnant patient refuses. So we have to counsel the patient, and even after the full counseling, she is not opting for the cesarean section. Ethically, we may be wrong on doing cesarean section in such a patient. There are some relative contraindications, but they are not absolute contraindication. We have to be extra cautious while doing cesarean section in these conditions, and we should avoid as far as possible. These are the conditions in which patient is having severe coagulopathy. She is having extensive history of abdominal surgeries in which we are expecting a lot of adhesions in the intra-abdominal, or if the fetus is dead, or it is having severe fetal anomalies. Because performing cesarean section in such a patient, we put the pregnant woman more at risk without any fetal benefit. So in a nutshell, we should avoid the primary cesarean section. We should use this procedure very judiciously so that we can prevent the future obstetric career of the female. So that's all from my side. Thank you so much.
Dr. Kanchan is there.
Yeah, excellent presentation, Dr. Shelley. As you always have a very crisp criteria, and in a very short, you have very nicely presented what are the maternal indication, what are the fetal indication, what are the feto-maternal indication. As we see that the chances, as you have very well said, of cesarean section are increasing nowadays because of many other cases, as was also said by Dr. Jayam, Kanan, because many times we are afraid of the complications and others. So very nicely you have covered. That's all.
Thank you so much. Thank you so much.
Thank you, Dr. Shelley and the chairpersons. Dr. Shelley, that was a crisp and clear talk. Moving towards Dr. Deepika, you want to play that video? Then we'll start the... Yeah.
Yes, ma'am.
Jagsonpal Pharmaceuticals Ltd proudly presents PRORETRO, micronized Dydrogesterone tablet 10 mg. Jagsonpal Pharmaceuticals is manufacturing all the active pharmaceutical ingredients and intermediates concerning dydrogesterone, making India self-reliant. Atmanirbhar Bharat. Vocal for local. Go for PRORETRO.
My teammate is here, ma'am, from our sales team, area sales manager, Mr. Shah.
Good evening to all respected faculties and delegates. I am Shah Mekrani, area sales manager from Naari division of the Jagsonpal Pharmaceuticals Ltd. Seek your support for our product. Presenting PRORETRO 10 mg tablets of micronized dydrogesterone, which is proven with its proven clinical efficacy and tolerability. Our brand PRORETRO is assisting motherhood and delivering happiness. This indigenous brand offers economical therapy to the patient at rupees 50 per tablet. Please prescribe for nutritional support in ART, IUI, and recurrent pregnancy loss. For the first time in India, we have Verana Nano Silver Vaginal Gel, offer a significant solution for accelerated healing with antimicrobial effect in cesarean section scar. It is stomy, post-DNC, cervicitis, and cervical erosion. Verana Nano Silver Vaginal Gel provides the goodness of colloidal nano silver particles and come with an applicator in a 40 grams tube to last full for 5-day therapy. Our other excellent brand is Celia M, with chewable strawberry flavored tablet formulated with an ideal of 40:1 ratio of a natural insulin sensitizer, mannitol and decarnitol along with L-methylfolate and vitamin D3 to restore the reproductive health. It helps to restore the ovulation, increase the insulin sensitivity, and improve the ART outcomes in PCOS women. We thank for your support so far and look forward for a long-term association. Thank you very much, respected faculty and delegates.
Thank you.
Thank you so much. With this, I hand over the conduction of session to very able and dynamic Secretary of Jaunpur OBGYN Society, Dr. Amber Khan, for the techniques of cesarean section. Dr. Amber.
Thank you, ma'am. Good evening, respected dignitaries, faculties, and all the delegates present here. I bring greetings from Jaunpur. So moving ahead to the next session, which will be covering various aspects of techniques of cesarean section. The first topic here will be incisions during cesarean section by Dr. Anita Rajoria, ma'am. And to chair this session, I would like to welcome respected Dr. Usha Goenka, ma'am, who is President Kanpur OBGYN Society, a very senior gynecologist and IVF specialist, HOD at Amba Hospital, Kanpur. Ma'am is a postgraduate in hospital management and in medical ethics and law. Ma'am is member of various reputed organizations. Once again, I welcome you, ma'am, to kindly introduce our speaker and chair this session.
Everybody. First of all, I should thank ISOPARB Prayagraj, Kanpur and Jaunpur for making me a part of this wonderful webinar. My heartfelt thanks and a special gratitude to my senior Dr. Ranjana Khanna. बहुत डांट खाई डॉक्टर साहब की. Also, I'm thankful to Dr. Amita Tripathi, Amber Khan, and Dr. Parul Khanna. My regards to our chief guest, Dr. Anuradha Khanna. I welcome our speaker, Dr. Anita Rajoria. She's always smiling, always bubbling with happiness. Dr. Anita Rajoria, her present designation is HOD and Senior Consultant, Department of Obstetrics and Gynae, Dr. Hedgewar Arogya Sansthan, Government of NCT, Delhi. Her present affiliations are Asia Oceania Federation of Obstetrician Gynecologists, Federation of Obstetrician Gynecologists of India, Association of Obstetric Gynae of Delhi. There's so many. Her major achievement is Founder Vice President of Delhi Gynae Forum, Chairperson at Adolescent Health Committee, AOGD, and many more. Her honors and awards are innumerable, and she has got multiple publications to her credit. I welcome Dr. Anita Rajoria to speak on incision in C-section, on skin and on uterus. Welcome, Dr. Anita.
Thank you, Usha ma'am. Thank you for that kind introduction. So I'll share my screen. So the topic assigned to me today is skin and uterine incisions in cesarean delivery. Is my slide moving? Yeah. Yes, so we all know that the main two types of incisions we usually encounter are longitudinal and transverse that are being used for cesarean. Longitudinal incisions can be either midline or paramedian incisions, while transverse incisions can be midline. Transverse can be Fannin steel, Jolecon, Cherney's, Maillard's incision, Kushner's, and so many. Now the advantages and disadvantages. There are certain disadvantages of transverse incision, like it is more suited for a planned surgery. There are less chances of wound dehiscence, cosmetically viable, lower incidence of adhesion formation, less painful for the patient, and there is lower incidence of incisional hernia. But there are certain disadvantages also. The disadvantages are that it offers limited exposure. If we want to extend to the upper abdomen, then we will face difficulty. There is limited extensibility. Then there are relatively, if the penis is large, we will find less space to work on. On the other side, midline incisions have advantages like they are more suitable for emergencies, or if your diagnosis is uncertain, or if you find that there is hematoperitoneum and you want to explore along with the cesarean, then midline incisions are said to be better. The rapid entry is always there, and it is suitable for patients in shock and sepsis. There is more exposure to upper abdomen. Extensibility, if need arises, is easy, and it has less bleeding and less potential for nerve injury. But there are more chances of wound dehiscence and hernia. These are the various incisions which are used for opening the abdomen, and mainly for cesarean we are using Fannin steel and Maillard incision at times, and midline vertical paramedian incisions are frequently used. We are all aware about Fannin steel incision. I need not go into the steps for this august gathering. We open the skin transversely 2 to 5 centimeters above the pubic symphysis. It is around 10 to 15 centimeters in length. You enter the skin, go to the rectus sheath, which is incised transversely. Upper and lower facial edges are grasped, and you elevate them with heavy tooth clamps and dissect blunt or by sharp dissection. You separate the rectus muscle from the umbilicus to the symphysis. Then you separate the recti along the midline and you expose the transversalis fascia. Now posterior rectus sheath, it is separated above the arcuate line. And you are going to incise the peritoneum vertically, taking care not to injure structures like bladder and bowel. What are the advantages? We all know that it gives excellent strength and cosmesis to the patient. There is adequate exposure, but there are certain disadvantages also, because if the surgeon is not experienced, then there will be restricted speed of entry. And there are more chances of seroma formation, they say. There are more chances of hematoma formation if you're not careful, and wound infection if the hemostasis has not been taken care of properly. Now, if the rectus sheath is required to be incised beyond the rectus muscle, you may injure iliohypogastric and ilioinguinal nerves. So, if this gets traumatized, some patients may experience chronic pain also because of healing and nerve entrapment, and neuroma formation can be the other cause of chronic pain. Now, Jolecon incision. It is a straight incision that is 3 centimeters below the line joining both anterior superior iliac spines. The skin incision is made 3 centimeters above the usual location of Fannin steel incision. Subcutaneous tissue is incised in 3 medial centimeters, and then the lateral tissue separation is done manually. And the fascia is divided by blunt dissection using both the index fingers. Advantages, of course, are less post-operative febrile morbidity, less analgesia requirement, shorter operating time, less intraoperative blood loss, and adhesion formation. Patient is up and ambulatory early, and there is reduction in the hospital stay of the patient. The wound infection is also less. Sometimes we are using Kushner's incision also. It is also a transverse incision. It is approximately 5 centimeters above the symphysis, just below the anterior superior iliac spine. After skin, you are going to separate the subcutaneous tissue from the rectus sheath in a vertical plane. Now it has to be opened vertically to reveal the linea alba. And you may find superficial epigastric plexus of vessels, and we have to ligate them to prevent excessive oozing. Then you dissect only enough to expose the linea alba, and you need not separate the subcutaneous tissue too far laterally. And then you are going to incise the linea alba in a vertical midline incision. So the theoretical advantages offered are decreased risk of hernia and wound dehiscence. While disadvantages, we are not using it so often because it is time consuming. There is need of extensive hemostasis. There is minimal extensibility. So there is limited utility of this incision, especially in cesarean. So this is a comparison of Pfannenstiel, Jolecon, and Kussner's incision. Now Maillard incision. Maillard incision is again a transverse incision at the level of anterior superior iliac spine, and before transection of the vessel, the deep inferior epigastric vessels are carefully identified on the lateral surface. If I may show it. So you are going to isolate the vessels on the lateral side, and before, it is a muscle cutting incision. So before transecting the rectus muscle, you have to isolate, clamp, and transect and ligate these vessels to avoid hematoma formation later on. Now these muscles are separated from the anterior rectus sheath, and do not dissect too much. Do not dissect too much because your muscle may retract. And if you want to be extra cautious, you may put 1 or 2 absorbable mattress suture 10 number to prevent further retraction. Now then the muscles are cut, and then they are reflected up on the upper side and on the lower side. So what are the advantages? It provides very good abdominal and pelvic exposure. The disadvantage is limited access to upper abdomen, and delayed bleeding from the cut edge of the rectus muscle may be there. Now there is one more aspect. If the patient is having significant ioto iliac occlusion for any reason, the blood supply to lower limb is maintained by these collateral vessels. And if you are going to cut and ligate this, the patient may have acute leg ischemia or claudication. So Chinese incision is also there. This is also similar to Pfannenstiel, except it is slightly lower on the abdomen than the Pfannenstiel. The steps are almost similar. The rectus sheath is open transversely and lifted off the rectus muscle in the lower part until you reach up to the pubic bone. Then you incise the incision is given laterally by perforating transversalis fascia to medial to the inferior epigastric vessels. And then you go, finger is passed below the tendons of the muscle, and then incision is made, it is cut, and muscles are pulled up. So this is another form because it will provide them good, visualization of the lower part. This incision combines the advantage of extensive exposure of Maillard's incision, and the added advantage is the strength, which is equivalent to that of a Pfannenstiel incision. If you need to do some work in retropubic area, it's a very good incision of choice, but rarely used in cesareans. Then others are vertical. We are all accustomed to it. There may be, you can use midline incision, you can use paramedian incision. Paramedian themselves may be paramedian, lateral paramedian, or pararectus at times also. If you find any, sometimes I remember one case in which the bowel was just adherent below the, below the abdominal wall. So we had to take a lateral, very lateral paramedian incision. Now, advantages of vertical midline incision are it is versatile, rapid, and it offers a very good exposure. And you can, extend it upwards if you want. But disadvantages are many. It is more painful. There is increased pulmonary depression, and Aesthetics is also less. So I need not discuss that. A linea alba is incised and muscles are separated in the midline. Peritoneum is opened at the kyphoid end of the incision, and peritoneal incision is extended longitudinally, slightly off midline to avoid urachus. The vertical paramedian incision, they offer advantage of less risk of herniation, improved lateral exposure, but disadvantages are that if you go too laterally, you can encounter inferior epigastric vessels in comparison to midline incision. So there may be injury to these vessels, and less cosmetic again like midline incision. Now, this is a catch-22 situation. If there is a big pannus, then क्या करें क्या ना करें कैसी मुश्किल है? Where will you put the incision in such a patient? So it is, the literature review says that you keep the pannus down and you give the incision above the pannus for a better healing. Now, raising a bladder flap. This is again a point of discussion, but it is not encompassing my topic, so I will not discuss. But at times you may find bladder reflection difficult, especially in adhesion cases. Now I'm coming straight to uterine incisions in cesarean section. So we have all seen these various types of incision, classical, then lower segment. Sometimes you need to do extraperitoneal cesarean also. And mainly we are concerned with the lower segment uterine incision. You can have various types. There may be low transverse, there may be high transverse, then there may be then there may be low transverse with T extension. There may be low vertical, low transverse with J-shaped incision. Then these are low transverse with bilateral J-shaped incision. Again, fundal transverse is also there sometimes, and classical incision, as madam has also already told about in her presentation. So a low transverse incision is preferable as it is associated with lower risk of rupture in subsequent pregnancies. Conversion to J or T shape can result in weaker uterine scar. Now, how to do blunt versus sharp hysterectomy? Will you cut it with scissors or you will extend with fingers? It has been seen that if you do digital extension, then there is lower drop in hemoglobin and hematocrit. So these are the incisions which can be used, usually transverse, but sometimes lower segment vertical incision may be required. Now, how do you extend it? Some obstetricians prefer to extend it laterally with the index finger, while recently there have been some reviews which say that cephalocaudal pulling gives a better, better this thing, and extension to lateral side is also less if you stretch the incision cephalocaudal. So again, various incisions used. Then, cesarean section is a very important thing, and incision of skin, exposure of uterus, then how to separate and how to deliver the baby will be dealt in the next presentations which are coming through. So please be very, very careful, because skin incision is the signature, your autograph on patient's abdomen, and patient will ever remember the signature on her abdomen. So I take this as an opportunity. This is my floral request with folded hands to bless me with your vote for Chairperson Medical Disorders in Pregnancy Committee FOGSI. So thank you so much, everyone. My regards to all my seniors. Thank you, Ranjana ma'am, for giving me this opportunity. And thank you, my respected chairpersons and all the faculty and dear delegates. Over to organizers. Thanks for a patient listening.
Wonderful presentation, Dr. Anita. You have covered every aspect of incision on skin and uterus. I wish you all the best for your endeavor for the chairperson.
Thank you, ma'am.
Thank you, ma'am, for this enlightening talk. For the next talk, which is on different suturing material and suturing techniques in cesarean section by Dr. Rima Sarkar, I would like to welcome the next chairperson, Dr. Rekha Rajendra Kumar, ma'am. She is South Zone Coordinator, FOGSI Infertility Committee. Ma'am is director of Miracle IVF in Chandana Hospital, Bangalore. Ma'am has been a great academician. We can see she has received various awards for being topper in many exams. She has received 12 awards and 3 felicitations, including national as well as international. She has many publications in reputed journals. So I request you, ma'am, to kindly introduce our speaker and chair this session.
Yeah, thank you, Ranjana madam. Thank you, Dr. Amita, the team of Jagsonpal seniors, as well as my colleagues. Thanks for accepting me here and giving me opportunity to be amidst all of you. Little bit outside the present topic where I'm chairing, like about the suture material. I just wanted to tell in the beginning that when we see the cases about the indication for cesarean, Dr. Jayam was telling, Madam was telling that it is the medico-legal issue. I very much agree with that. And the point I would like to put forward here is that it is most of the times in my practice or even small institutions, unlike the bigger ones, where you don't have a regular anesthetist. That is the big problem I feel most of the times, because the anesthetist in our places, like small places, they are the visiting anesthetist, where they'll be in the traffic signal. They say they are in the traffic signal, but they will be giving anesthesia in another hospital. They say, I'm parking my vehicle here, but they are nowhere to be seen. But the fetal heart will be sinking like our heartbeat. It will be sinking to 60, 70, you see in the topography. These are the very fear of not getting the anesthetist. Availability of anesthetist not being there itself is probably making us say 20% earlier the decision to make a cesarean. Yeah, this is a pediatrician, at least we have all the time, whether it's a normal or a cesarean we have. But anesthetist probably most of us call only when we need, like we think of cesarean. So that is one thing I would like to say. And second thing is like the contracted pelvis, as some doctor said, is an indication for cesarean. It's absolute indication, or probably the cephalopelvic disproportion, however we take it. But probably in future, because of non-availability of the vaginal route, will the pelvis of the female contract? Like, will it become a shrunken pelvis? That would be the another thing I would like to say. And also I think that the another thing is the as Jam madam said, she said the cost of vaginal delivery versus cesarean. I think the our stand should be like the cost of vaginal delivery. In some hospitals it does happen that the cost of vaginal delivery is more than the cost of the cesarean section, because it is the marathon observation and the risk that is taken, the hypertension or whatever the problem the doctor goes through. So all these things probably make it a very challenging situation. And a normal delivery, you say it is probably a retrospective diagnosis. When you have the baby in hand, then you say it is a normal delivery. This is what I know that I've talked a little outside the destined topic where I'm supposed to chair, but I just wanted to put forth my observation or my opinion also. Please excuse me if I have gone beyond what I'm supposed to speak. Okay, now let me come to what I'm supposed to talk. The Dr. Rima is going to talk about the different suture materials, what we do use in and out in the cesarean cases. Probably it is the uterine incision suture material or the skin suture material. There are so many doubts that lurk in the patient mind when we talk about the suture material. They're worried about the scar. They're worried about the suture removal itself. That is a big procedure. She wants her mother, she wants her husband holding the hand when we remove the sutures. So those issues are not there now because of the absorbable sutures. She's worried about the cosmetic aspect of it, etc., etc. Okay, let me not elaborate on this. Let me give the opportunity to Dr. Rima Sarkar. It's my pleasant task to introduce Dr. Rima. She is a fertility consultant and the IVF specialist. She has also done her fellowship in reproductive medicine. She has her ICOG fellowship in gynec endoscopy also. She is a center head and consultant IVF specialist in Indira IVF, Dehradun. She is also the ex-associate professor OB-GYNEC in GMC, Faridkot, Punjab. She has more than 10 national and international publications to her credit. She has also contributed more than 15 chapters in various gynec books, reviewer with Panacea Journal of Medical Sciences. She has also bagged the Wonder FOGSI Award in 2019. Over to Dr. Rima Sarkar. The floor is yours.
Thank you so much, ma'am. Thank you for the kind words and that heartfelt feelings of yours. Thank you so much. So, good evening all. I am Dr. Rima Sarkar. सबसे पहले सारे बड़ों को मेरा बहुत ही विनम्र प्रणाम. And of course, a very special thanks to my Prayagraj family, ISOPARB Prayagraj, Dr. Ranjana Khanna ma'am, Dr. Amita ma'am, Dr. Manju Verma ma'am I saw somewhere, Abhilasha Di, Parul, thank you so much for remembering me and having me here today evening. So, in my talk on LSCS today, I'll be focusing mainly on suture materials and techniques. We all know the technique and the suture material used are crucial and paramount because they are the main determinants which are going to determine how the uterus scar is going to heal. And as obstetricians, all of us have been conditioned to a scarred uterus. It is like a sacred uterus to us because we all know that not only the consequences would be long-term, but they can be very, very worrisome too. So there have been multiple techniques and suture materials which we all have been using from time immemorial for the closure of uterus during cesarean section. However, there has been no compelling evidence so far which would categorically put one particular technique or one particular suture over the other and tell that this one is better than the other. So uterine closure can be done either in a single layer or by double layer. We all know that. Also, the point of concern or point of talking for us would be whether we should be locking our sutures or we should be leaving them unlocked. Of course, each and every surgeon would kind of do a risk-benefit analysis before opting a particular technique, and that is what we are going to look at today in this presentation. Single versus double layer closure, I believe, is going to be covered in a subsequent session. So I'll just wrap it up with this Cochrane review, which found no statistical significant difference between either of the technique, and RCOG, which does not recommend the single layer closure, and it does say that other than the research content, the closure should be 2-layered. Locking versus non-locking sutures, this is what I'm going to concentrate more on. And when I looked up the literature, this was a study which was most widely, cited. So this was a meta-analysis actually, and it demonstrated that the double layer uterine closure, that when we close the uterus in 2 layers with the first layer unlocked and exclude the decidua, this is associated with a greater residual myometrial thickness and healing ratio. And this technique is associated with better healing of the uterine scar as compared to when you take a through and through single layer closure, which includes the decidua. Which means that a locked single layer closure would be associated with an increased risk of uterine rupture as compared to the double layer closure. I found this another study which also supported kind of decidua exclusion. They also said that if you include the entire thickness of the uterine wall and bring decidua into the scar, so this will hamper the uterine healing and it would be defective. However, when the decidua was excluded from the suture, all their cases in their study, they resulted in perfect healing. In contrast to my previous 2 studies, which talked about decidua being excluded, I found a contrasting opinion, which was given by this gentleman, Junwoo Han, in his study, who showed that the main causative factor of this myometrial residual thickness is actually the coaptation ratio of the incised myometrium. If you would follow this pen here, so this is, let's say, an incised wound. So this is a serosal layer, this is the decidua, and in between is the myometrial layer, and these are the 2 cut-off edges. So this pictorial diagram is regarding a through and through single layer closure that they have done. And what he said was that no matter what you do, if you take a single layer closure, then these points, A0 and A0, which were supposed to come together, they never actually come together after this kind of closure. This picture represents immediately after closing. This C picture is after the absorption of the suture, and this D represents the final after remodeling. So in all the cases, you can see that these 2 points actually, which were supposed to be overlapping after incision and after a single layer closure has been done, they actually never come, they never become one, and they go far apart. And this is what was bothersome according to him, that the coaptation ratio, it changes with this kind of suturing. And so what he suggested was that the decidua in fact should not be completely excluded. So he said, let's say this D1 is the point where your needle would come from here to here. So he said this D1 to D0 distance, that is, your needle should be as close to the inner margin as possible. This should be kept as short as possible. And so decidua, according to him, should not be completely excluded. Even on complete and thorough literature research, I actually could not find any conclusive evidence on whether to exclude the decidua or to include it. However, it is now left on to the surgeon's discretion, and we need further studies on that. Although I did find this, all these studies favoring that the first layer should be kept unlocked. Why is this so important? Because what are we scared of? We are scared of conditions like isthmocele, which is actually a uterine scar defect, and it results directly out of poor healing of uterine incision. It is a troublesome condition where the woman keeps experiencing menstrual spotting, dysmenorrhea, dyspareunia, chronic pelvic pain, and an increased risk of scarred pregnancy as well, along with placentation abnormalities. And of course, there is always a risk of uterine rupture in the future pregnancies. And all this why? Because the uterine closure technique was not taken care of and during the previous section. And so that makes it even more important. So this is one study that I found that said far, near technique, continuous unlocked double layer technique is beneficial in terms of providing protection from isthmocele and ensuring sufficient RMT. And I think most of my seniors and teachers would agree with that. So this is another topic which I wanted to bring about. Most of the surgeons I have worked with or I have seen, they are in habit of exteriorizing the uterus, and there has been some evidence, whatever I could collect, on whether to keep the uterus internally or to exteriorize it. They said it is associated with more pain, and it does not actually improve the operative outcomes such as hemorrhage and infection. In fact, but however, some other studies did say that there is no other benefit other than maybe reducing the blood loss and the associated decrease in hemoglobin. And of course, there was no difference between the two techniques with respect to intra or post-operative nausea or vomiting. Coming on to uterine, coming on to the sutures that are used for these incisions. Anita ma'am, sare incision tarah ke laga ke chale gaye hain. Let's close them up. So what all materials are you going to use? All of us use absorbable sutures, either of number 10 or number 1. And the commonly used suture materials are chromic catgut and polyclactin. Chromic catgut, being a natural suture material, has comparatively marked tissue reactivity, inconsistent tensile strength, retention, and reabsorption. Let's look at it one by one. Catgut, we all know it's a natural suture material. It is derived from the submucosa of sheep intestine or cattle intestine. Chromic catgut is a modification where the plain catgut is tanned with chromic salts, and this is done to improve the strength of the suture. Tissue inflammation. This kind of suture is associated with marked tissue inflammation, which can be detrimental to healing, and it may lead to more rapid breakdown of catgut. Plain gut has a median survival time of 4 days, whereas chromic gut retains its strength for 2 to 3 weeks. Again, we all know it is a stiff material and we need to moisten it before we use it, and it forms knots that can be irritating to the tissues. Infection rates may increase with the use of gut because it is a braided kind of a suture. And also it is derived from gut. The advent of synthetic materials with less tissue reactivity and more predictable resorption has almost made catgut now obsolete. So what are we, most of us using nowadays? Polygalactin 910. It is an absorbable, braided, multifilament, coated synthetic suture. It is a heteropolymer and it is available even with antibiotic impregnated on it. The residual tensile strength is consistently greater and it is absorbed more rapidly. Absorption starts at 40 days and completes by day 70, and there are no remains left by day 90. So it is a delayed absorbable kind of suture, and the advantage is that it elicits less tissue reactions and promote faster wound healing. Next is polyglycolic acid, Dexone, and the newer one, Dexone 2. It is a synthetic, again, braided polymer. It is less reactive, more resistant to infection, excellent knot security, and maintains at least 50% of its tensile strength for 25 days. Main uses are for closure of superficial fascia, that like subcutaneous tissue in wounds and ligature of small blood vessels. The main drawback is that it has a high friction coefficient, which all of us have actually, faced also, that it binds and snags when it is wet. And so it is difficult for it, to seat your throws during knotting. However, this has been taken over by a modified kind of variety, which is called Dexone Plus. It is coated with poloxamer 188, which reduces this friction, and this is a better kind of suture than the previous one. So the lesser throws can be are needed for this kind of suture. 3 to 4 would suffice, and there is less knot slippage in this with this kind of suture. So there was this study which was done to assess different suturing techniques and different materials on healing of uterine incision in Caesarean section, and it concluded that the best uterine scar was seen after using one layered interrupted vicryl and Dexone suture, and the worst healing results were obtained after 2 rows of interrupted and continuous sutures using catgut. So catgut is totally obsolete now. As compared to catgut, use of synthetic sutures were associated with thicker myometrium also in subsequent delivery, which would of course make a better scar. And why is that? Increased inflammation in natural absorbable suture may lead to increase in fibrosis and impaired healing, rendering difficulty in subsequent pregnancies and delivery. So there was this trial, Coronis trial, on the Caesarean section surgical techniques, which compared chromic catgut and polygalactin 910 for uterine closure. And they showed there were no statistically significant difference in the primary outcome, which was composite of death, maternal infectious morbidity, or further operative procedures, or the need for blood transfusion with either of these suture materials. A 3-year follow-up study was also done for this trial, and again, there was no evidence of a difference in the main comparisons for adverse pregnancy outcomes in subsequent pregnancies, such as uterine rupture. This was the findings of this trial. So to conclude from all of this is that both chromic catgut, polygalactin 910, number 1, 0 or 1 can be safely used for uterine repair during Caesarean section. Your situation, if you can afford polygalactin, this would be better to be used, keeping up with the present times. Closure of peritoneum, always been a debatable topic, and I hope my teachers are not listening to me, because the recent data now does support that there is no use. Even RCOG recommends that neither visceral nor parietal peritoneum should be sutured at Caesarean section, because this reduces operating time and the need for post-operative analgesia and improves maternal satisfaction. Rectus muscle reapproximation, again, some people do it, some people do not, debatable. It increases immediate post-operative pain. Mothers, they need more analgesics in the post-operative period. And there is no, although there is no difference in operative time, surgical complications, maternal satisfaction, but it was seen that rectus muscle, if you close, it did reduce adhesions to some extent. And if you do choose to close it, then use absorbable sutures such as chromic catgut and polygalactin 910. Rectus sheath closure, different techniques, suture materials are used again. Few general principles are to be followed. And what are those? All sutures used to close the musculofacial wall must be tied with enough tension. The tension has to be taken care of, although it should not be lax, but it should not be very tight also, because if greater tension is applied, the tissue will become ischemic and necrosis will develop, and you will soon start getting all those kind of discharges from the wound. So please, and of course this comes with experience. The suture should be placed at least 1 to 1.5 centimeter from the wound edge. In patients at increased risk of wound disruption, please feel free to keep these sutures almost 2 centimeter from the edge. The commonly used technique is to put continuous sutures without any locking. However, some people also use interrupted sutures. And continuous sutures, when used in one layer, it avoids high tension on the suture and does not compress the wound edges. Also, this would prevent devascularization for obvious reasons. Running sutures have the advantage of speed also, since knot needs to be tied only at 1, 2, or 3 points. However, as I said, interrupted and figure of 8 sutures can be used for reinforcing in thin rectus sheet and has an advantage of not coming apart if insecurely tied. Because I remember for all those cases where we had a thin rectus sheet because of previous surgeries or in case of previous wound dehiscence, we were always taught to put interrupted sutures which would hold even if 1 or 2 give way. So it is routinely performed with only non-absorbable or delayed absorbable sutures, and the commonly used suture materials are either polyclactin 910 #1 or polypropylene #1. Suturing of the subcutaneous tissue, again a debated topic, although they say that if it is more than 2 centimeters of subcutaneous tissue, it is nicer because it reduces the collection in the space and also decreases the wound tension. But studies do show that it really does not affect the long-term cosmetic outcome. So again, it is your choice whether you want to close it or not. Skin closure, as Dr. Neeta ma'am also said, it is like your signature. So it is what, no matter what you've done inside, your skin has to look good. So good approximation will give you cosmetically good scars. Everyone knows that. And also your techniques should be speedy, economical, and they should still give good cosmetically acceptable scars. Various techniques have been used. Some people use continuous subcuticular stitch, some use interrupted mattress stitch. Staplers have come, and adhesive compounds are the latest in the race. Suture materials that can be used are either natural, synthetic, absorbable, non-absorbable, single filament, or braided, whichever one you can use. Mattress sutures, which most of us are, I think, used to putting, they have an advantage of occluding the dead space and keeping the skin edges everted without tension. The disadvantages that I haven't actually seen it, but it was mentioned that they can be prominent suture marks as sutures tend to be removed later. To overcome this disadvantage, they have introduced something called intradermal buried vertical mattress sutures. I am good with the traditional ones also, but those of you, there is something called intradermal sutures also. Subcuticular suture, a blessing, first described in 1980. It is a cosmetic stitch. More difficult, so I won't say it is. It probably needs a little more practice, but it is a good choice, especially in younger women whose skin is soft and supple, and hence it makes approximation easy. It is preferable to use absorbable suture for this stitch as the ends are also buried. It has a better patient compliance than mattress stitch. But the point to be noted is that the post-operative scar assessment at 6 weeks actually yielded similar results in both. So again, it's a matter of choice. Staples are attractive. All of us are, especially we've been doing cesareans back to back, the speed of application is a very attractive, this looks attractive. This RCT showed that surgical staples were significantly associated with higher incidence of wound disruptions. So a word of caution here. So this also showed, another study also showed that the wound complications were higher and cosmesis was similar. So please, I would suggest spend a few more minutes, and I'm really not one for the staples. So if one wants to use staples, then there is something called absorbable ones that are better than the metal staples. So better to use those ones. Tissue adhesives, as I said, are the latest one in the race. They have a lower infection rate, less operating room time, good cosmetic results, lower cost, ease of use, immediate wound sealing, faster return to work. elimination of needle stick injuries, and eliminating the need for post-operative suture removal. It would seem like I'm really advocating tissue adhesives, but I have actually found them good. And an RCT also says that skin closure with glue or synthetic subcuticular suture have similar outcomes with respect to surgical site infection and wound disruptions, then why not use it? If you do use, the commonly used adhesive is octyl 2 cyanoacrylate. And again, that's all that I had to say, but I would thank the organizers for choosing such an important topic and going over these again and again, because we do need to do whatever we can for our mothers. Life ultimately comes from the mothers, and no manuals can help us there. Thank you.
Thank you, Dr. Rima. You explained us two important things. Part one of your talk was about the technique of closure, how to close decidua, include layer 1, 2 layers, etc. Part two of your talk was on the suture materials. I don't have any question because I feel that you've covered everything, including up to the adhesives, the absorbables, everything. Probably one small point, my suggestion, I may be wrong, that you should have added a bit on the needles also, like what kind of needle, where we have used. Everybody knows, but still it's just everybody knows here about what needle we use, but just a matter of fact to include, that's all. I don't have anything extra to say because you've covered everything A to Z. Thank you for that lucid presentation and covering everything.
Thank you.
And Dr. Ranjana, may I say something? Should I?
Ji, Anuradha ji, boliye.
Okay. Just what I notice in my clinical experience of more than 42 years, that since we have started doing single layer suturing, the incidence of placenta previa has increased. And now we have reverted back to two-layer suturing.
Yes.
So this is very important. And I'm telling you, I never did in my life single layer suturing with the locking system. Because I keep on thinking, if we are locking, we are squeezing, we are creating ischemia. Why should we create ischemia? If you see any leader in between, you give a figure of 8, no problem.
Exactly.
Spend the time with the patient. That is the law behind each and every surgery. And it's always I prefer to have two-layer suturing. So this is very important. What I learned in my 42 years experience, that suturing should be like that. And one thing more regarding peritoneal closure. Though it is said that data is like this, don't go for it. But personally, I don't mind in putting 1 or 2 approximating sutures just as such. Not the suturing over the peritoneum. Especially if the incision is larger, that I feel like that is no harm. And one point a doctor has given, Dr.
Rima.
Dr. Rima, not before surgery. Rima has did a wonderful job. Dr. Archana, I think Dr. Rekha, Anita, Dr. Anita has mentioned about the bladder reflection. So that point is very important. Yes, Dr. Anita, I can see you now. So that point is very important. If you see it is badly adhered and it is badly scarred also, better not to touch it. Give an incision above it. And just pushing it down, pulling it down will be more dangerous, harmful, making a fistula. So that was, I think Dr. Ranjana will have a second session on stuck situations at cesarean section. Yes. That will be very important. And I never like T incision. T is never, because if you feel any ring, internal constriction ring, then you give a J. J is much better to be given and to be hit. Never a T, neither on the abdomen nor on the scar. So it's a wonderful talk, though I'm busy here and there, but I keep on listening. Everything is going so well. Now I think I'm going to listen Dr. Ranjana. Thank you so much for this excellent webinar.
Single versus double layer Shaijas is going to speak. After that, we'll back.
Okay.
Yes, that is important because even if one J-shaped is not doing your work, you can make it bilaterally. You can make J-shaped. It's like a flap door kind of incision. It will give you enough space to work on.
Yeah. Thank you. And Anuradha madam, just one point. You said in your 42 years, you have never done a single layer closure. Will it not be okay if you have maintained hemostasis, approximation, everything you have maintained. Suppose you are doing in the same sitting tubectomy, isn't it okay to do a single layer closure?
No, never. How tubectomy keeps on making any difference on one layer or two layer. You have to spend time with the patient. We are there for the patient.
Going to challenge the section, that scar for the future pregnancy. So if you're approximating well, if you're maintaining hemostasis and approximating well, can't you give a single layer closure in that patient?
You never know. You never know.
You
When
never
she will
know.
come to you and say,
Yeah.
ma'am, reopen career. And not only this.
And then plus failed, failed tubectomy, the chances are there during cesarean if you do a tubectomy.
If you see Dr. Rekha, after
what
suturing, after 48 hours, all the scar is loosened, whether it is two-layered or it is a lock. So, but if you have approximated in 2 layers, it is much better than a single layer.
Right.
We always do double layer, but just wanted
Now,
to know whether we can do single layer
Dr.
further.
Rekha, now Shaijas is going to speak in detail about single versus double.
Yeah.
So I think let's move on to Shaijas.
We are eating his topic.
We are stealing his show.
Yeah.
Stealing Shaijas show. Sorry, Dr. Shaijas.
Yeah, Amber.
Thank you.
Moving ahead after this wonderful discussion, I welcome you for the next session, which is on single versus double layer by Dr. Shaijas. I welcome Dr. Poonam Goyal ma'am to chair this session. She is HOD and IVF specialist at Max Hospital, Delhi, and director and HOD at Panchsheel Hospital. Ma'am has authored various books on high-risk pregnancy, C2D, that is conception to delivery, endometriosis, and fibroid. She has received many reputed awards, to name few: APJ Abdul Kalam Excellence Award 2019 and Wonder Foxian Award. So, ma'am, I request you to please introduce the speaker and chair the session.
Thank you. Thank you, Doctor. First of all, my sincere thanks to Dr. Ranjana ma'am for remembering me for this. Now I invite Dr. Shaijas, a vibrant personality of FOGSI. He is currently chairperson, Midlife Management Committee, and he is president of Kannur OBG Society, joint secretary, Kerala Federation of OBG, and past chair research committee of Kerala OBG Societies. And I was just seeing the CV of Dr. Shaijas, and I was surprised to see there is not even a single award which has not been bestowed on him by FOGSI. FOGSI, Mrs. Shalja Pandit Women Empowerment Award, then International Traveling Fellowship Award, Superstar Award, then Dr. Kamni Rao oration was done by him in 2018. Then Dr. Tank Reproductive Healthcare Trophy, then Dr. Sadhna Desai Population Stabilization Prize, Dr. Durusha Youth Trophy. Then I think there are so many. We will just move on, and Dr. Shaijas will just tell us about the closure which we were just discussing. I think this webinar is going very interesting, and we must do a second session, Dr. Ranjana, please. Because that will only complete everything about this pitara which you have opened. So, Dr. Shaijas, please.
First of all, thank you so much, Poonam madam, for those really kind words. And thank you, Ranjana madam and ISOPARB, as well as Kanpur and Jaunpur ONG societies for giving me this opportunity. I don't want to mention more names because we are running a little bit behind time, and I don't want the next lectures to get delayed. Looking at the entire discussions that we were having all this time, courtesy, the wonderful lectures given by my previous speakers, I was just thinking that thank God this topic and this particular discussion is happening on a virtual platform. Because when you present something like a topic as controversial as single versus double-layered closure, you are at the risk of getting attacked by 50% of the people who are listening to you and getting hugged by the other 50. Because you either follow one of their opinions. And everybody is so strong. Nowadays, I say that even if you talk to an intern or a house surgeon, even he or she will be talking about his 3 months of experience in OBG and all that. And obviously, on the other extreme, we have people who have been in practice for 40, 50 years, much more than my own age. So I think with all due respect, let me try to do that balancing act on what evidence is available and what is probably the middle path that we can take and what understanding do we have regarding this closure. Now, if you look at the type of genes that is getting produced, it used to stay at the waist years before, and now it has become a low waist, isn't it? And this gap that you can see on the picture is called the generation gap. Okay. And I feel sometimes the arguments between a single and a double-layered closure is something like an argument between two generations. On one side, you have a young obstetrician who has probably just passed out or in his early years of practice, who basically believes that speed is everything. Okay, wants to finish up that cesarean section fast and get back to the next one or get back to his work. Somebody who's thinking about time as the primary factor. And on the other hand are those extremely experienced obstetricians who always believe that every layer in the body which is opened has to be closed methodically. Enough and more time has to be spent on closure. So it is primarily an argument between two generations. And obviously you will find some odd people of either categories where you have an experienced person also believing in single layered closure, or you may have a fresh pass out who's too influenced by his teachers and still does double layered closure for all. So I think we need to strike a balance somewhere, because we need to look at evidence and try to understand which is the guarded approach. Okay. Now, this is something the lectures by Dr. Anita as well as Dr. Rima, I think, has laid a fertile soil for me to just plant my seeds and probably launch on. The risk of uterine rupture during a trial of labor is the primary concern whenever we are talking about a uterine closure, and that becomes the most significant factor that has to be assessed. We all know that it is done by ultrasound, and there are two things which all of us need to remember. We are talking about a lower uterine segment thickness, which is the full thickness measurement at the lower uterine segment, and something called a residual myometrial thickness, which is probably the thickness of the myometrial wall at the site of the previous hysterotomy. And if you look at this figure, you'll understand that the figure might appear a little bit too complicated, but just look at this double-edged line, double arrowed line, and this will tell you that this is the lower uterine segment thickness. The two pictures on either halves are one done by a trans-abdominal assessment and the other by a trans-vaginal assessment. And the small line without an arrow that you can see is the residual myometrial thickness. Okay, so only two measurements which will primarily determine where we are heading to. Okay, one is the lower uterine segment thickness and the other is the residual myometrial thickness, which is the RMT. And defective RMT has been linked to increased risk of so many adverse outcomes. One is post-menstrual spotting, uterine dehiscence or rupture, placental adherence, so failure of trial of scar and other complications of cesarean scar on pregnancy. Just to add on to the discussion that you just had immediately, so this closure technique is not just related to whether she's going to get pregnant next time and whether that scar will withstand the trial of labor. There is something more than that. We are also talking about menstrual symptoms that can happen because of an inappropriate closure. Okay, I hope I'm able to convey that particular point. So it is not just pregnancy related, it may be something more. So the primary factor that will decide all this is your type of closure. And it will also decide whether there's a chance of development of a uterine niche and subsequent CS related outcomes. So closure technique affects residual myometrial thickness, as I already mentioned, and the healing of the uterine scar. However, clear evidence of the best method for uterine closure is not yet established, and no evidence-based guidelines for the closure technique are there at this point of time. So when evidence is so scarce, it is always better to look at some meta-analysis, a combination of RCTs and what it can tell you in a balanced manner on how to go ahead. What did the earlier studies tell us? The earlier studies very clearly told, as Anuradha madam rightly pointed out, that double-layered closure leads to a thicker residual myometrium. and a lower incidence of larger scar defects than a single layered closure. There is absolutely no doubt on that. Okay. And this is what the earlier studies have told us, that it gives you a thicker residual myometrium. However, a clear conclusion about the other clinical outcomes were lacking with the studies that have been available till recently. And then there came the Cochrane review, those guidelines which have been adopted by the RCOG, and there are some wonderful systematic reviews that have happened all across the world. Let us look at a few of them. Now, this meta-analysis primarily looks at a comparison of the ultrasound findings and the complication rates of single layer versus double layered uterine closure technique. So here we are primarily not looking at just how anatomically good it appears on ultrasound. We are also looking at whether that makes a clinical significance as far as the patient is concerned when she gets pregnant one more time. Okay. 3,926 articles and almost 19 RCTs came out of that, which are considered eligible for inclusion into this meta-analysis. So let us see what does it actually say. Now, one thing is very clear, as I already mentioned, which agrees to the earlier evidence that we had, that a double-layered uterine closure is better than a single-layered uterine closure with regard to an increased RMT, that is residual myometrial thickness. There is no doubt on that. It also tends to cause lesser dysmenorrhea in these patients. So other than pregnancy, we are also talking about a menstruation-related symptom. So if you do a double-layered closure, you're more likely to have a thicker RMT, and then you have a lesser chance of ending up in dysmenorrhea. Now, results regarding RMT were more evident in this meta-analysis when locked sutures were compared. Mean to say that a single-layered closure with locked suture, comparison with a double-layered suture with a locking suture. When that was compared, double-layered showed a little bit more advantage. That means the difference was more gross, more evident when locked sutures were compared. Obviously, there were unlocked arms also in it. Okay. Now, thicker RMT with a double-layered uterine exposure is definitely an expected one, because you are separately closing the myometrial as well as the serocell layer. So obviously you expect it to be very thick, isn't it? You're looking at a good approximation of layer to layer, and you're also looking at a wonderful coaptation ratio, as Dr. Seema rightly pointed out. Now, remember this, those were the anatomical changes that have happened because of good approximation, and those were your ultrasound findings. Now, whether it really makes a difference for the patient clinically. Now, what this analysis or meta-analysis of 19 RCTs tells us is that both techniques showed comparable results. There's no advantage of one over the other with regard to the amount of blood loss, the healing ratio, the duration of hospital stay, the risk of maternal infection, readmission rates, and the last one is the most important, the risk of uterine dehiscence or rupture during a subsequent delivery. So if you tell me that if you are a person who believes and who always does double-layered closure, and you are doing that to increase the RMT, that is increase the residual myometrial thickness, you just want to ensure that the residual myometrial thickness is good enough, then I totally agree to that. But if you tell me that you have been doing a double-layered closure to ensure that she has lesser chances of rupture during a subsequent pregnancy, then there is no evidence at this point of time to substantiate that. I hope I have made my point clear. Now, what about, is single-layered closure that bad? Now, single-layered closure also can give you advantage, but that advantage is primarily related to the operative time. As I told, if you have a function to attend, then probably you might be thinking of single-layered closure, isn't it? That's on a lighter vein. I'm sure that Anuradha madam is having a smile on her face. We are expected to spend enough time on the patient. So just for the want of time, it should not be a belief on single-layered closure in comparison to a double-layered closure. Now, there is also a recent RCT that has come up and told that single-layered closure is associated with lower niche prevalence, lesser need for treatment for other gynecological complications, and less harmful effect on sexual activity and general health. This is in total contradiction to whatever we have learned from that other meta-analysis. So we need to agree that evidence is evolving, and depending on whatever we believe in, we can actually gather as much as evidence as possible in support of that. They always say, no, it's a very interesting game. So if you are a good speaker and if you want to push in single layered closure, you can gather enough and more evidence from around the world and push your point into the other people's mind. If you are a person who's believing in double layered closure, then you have enough and more evidence to support that also. Now, the concluding remark would be something like this. Now, double layered closure showed better sonographic outcomes that is primarily related to the RMT, as revealed both by the past as well as the present studies. But these outcomes are unfortunately clinically insignificant as far as the rupture rates are concerned. That is where there is a concern regarding this. Thus, for the time being, there is no clear evidence to say that a double layered closure is superior to a single layered closure at a cesarean section. Now, what is the moral of the story, which I have mentioned over the last 10 minutes? Now, the moral of the story is you may continue to use a double layered closure if you believe so, irrespective of whether your experience is hardly for 1 year or you are a person as experienced as Anuradha madam for 40 plus years, which is tremendous, okay? Because they talk from their experience, they've obviously seen more number of patients than a person who has just started practice. But just remember one thing, don't get too judgmental about your colleague who believes in a single layered closure, is the moral of the story. Because there is not enough evidence to substantiate that the sonographic outcomes that we have seen is actually translating into a clinical significance. Now, if you are that youngster or even an experienced person who believes in single layered closure, remember that there is a concept of layer to layer closure, which is applicable for any kind of wound healing. And that also applies to a cesarean wound also. And there is also the added concept which Seema rightly pointed out, something called coaptation ratio, which is a point-to-point approximation. And you tend to believe, even if there is not much evidence related to it, you tend to believe that when point-to-point approximation is better, that wound may behave better. Fine. So, irrespective of whether you believe in a single layered closure or a double layered closure, always have a guarded approach about your technique of closure. Be open to suggestions. Just keep on looking at what evidence is accumulating. Maybe what I am telling today, maybe 6 months later with some better evidence, I might have to reframe. So be open to suggestions, understand that there is some amount of limitation, and more importantly, we all need to believe this. It is just not on suture material or technique or RMT that a cesarean scar will give way or not. It is primarily depend on the pattern in which the lower segment is going to expand, and that definitely varies from person to person. That is why you might have a single layered closed woman easily delivering vaginally, and you might have even a double layered closed woman ending up in a uterine rupture, because there are much more important factors involved in that healing. It also is related to the healing ability in a patient. Healing ability in a patient, which also decides how strong the scar would be. We generally, as obstetricians, we tend to take up all the responsibility. We feel that if I close, it will not rupture. If I close in 2 layers, it will not rupture. No, it's never that way. However well you close, however experienced or inexperienced you are, irrespective of your ability to close, there is a healing which happens from the patient side, and that also becomes a determinant factor. And that is why there is not much evidence telling that there is one technique which is superior to the other one. And I hope I have not made too many enemies. I hope that I don't hope that I have made too many friends also, because it's a very, very controversial topic, and probably we need to strike the balance between the two. But I think the moral of the story would be open to suggestions. Be always open to change your technique. There might be some new evidence coming up which might teach us something new from what we have learned earlier. So thank you so much, Ranjana madam, for that opportunity. It's been a pleasure. I have also learned a lot just sitting half an hour prior to the lecture and listening to all of you wonderful experienced people, because I think everyone, irrespective of however less experience or more experience you have, I think you have a point which you're making. And I really appreciate that. And thank you so much for this opportunity.
Thank you, Dr. Shajas. That was a wonderful talk, very wonderful. You have very beautifully highlighted everything. I would just like to share, when this single layer came, I immediately shifted to single layer. And after that, then I started taking the lower segment thickness, because I do my scans. So I started noting down the lower segment thickness in those particular patients. And all single layer. There is, I have one junior, she never closes single layer. She always does double layer. And whenever I will do the lower segment thickness, the cesarean which was done by me, that will come out to be 2 mm, 3 mm, and hers was always good. But I never dared to try labor in those particular patients because of the less thickness of the lower segment on the ultrasound. Though, as you are saying, that doesn't signify the rupture or non-rupture. But if I have noticed a very thin lower segment, I will not dare to go for VBAC in that particular patient. That is the problem. So I think for now on, as Anuradha madam has said, we should stick to that protocol till we have any other, new evidence. So we should spend time with the patient and do a proper closure. Like Anita has said, Rima has said, and now Dr. Shaija said.
And Dr. Poonam, not only the scar dehiscence, but also the placenta previa I was mentioning.
Yeah, ma'am.
And
another thing is that I will see whenever I am doing the scans of post-cesarean patients, you will see very, very large niches formed in the cesarean scar. And then I started reading the whole literature, and I found that to look at, you will see that hardly 2 mm of my metrium is there, and the niche is, this much finger, like this much thick, wide niche will be there. But that literature says you don't need to repair that niche before allowing the patient for her second pregnancy, because they say that even after your second repair, there may again be niche formation. So I don't know where we are going in this because of the rise of cesarean section rate. So many complications which are coming that are really, difficult to handle sometimes.
But I agree with Dr. Shaija that we should be open to suggestions, and we should be open to the latest reviews. So Shaija, I agree with that, though I personally always stick to double layered closure.
And Shaiza, one more thing. Scar pregnancy. Scar pregnancy. So these all because of this, I think I have opened one case, did cesarean. She had previous scar, single layered. I inquired from the doctor who did it. And that baby was no more after that. And second I did, she had chorioamnitis that time in intrauterine infection. And the scar was only 2 mm. I performed at 34 weeks. And then she became pregnant, and that time when I was stitching. So what I did that I was making that area more fresh after taking out the baby, and I did it in 2 layers. That third time when she became pregnant, then I was the person to follow her up, and I continued the pregnancy till 37 weeks. And I did myself cesarean section. That time the scar thickness was 4 mm. So that's why I learned from my technique, my patient, and other. We all are learning with the patient.
Yes.
So that's why I concluded myself that why not to go always for double layer, and whenever there's any bleed, make a figure of it. And not only this, I put a figure of it with the starting from one end to before that the another end, so that both the points are tightly constricted. Now you keep on taking the sutures. They should be tightly stitched together separately. That is very, very important point I learned in my practice. Thank you so much.
Another thing I will like to point Dr. Rima had said that some people, they exteriorize the uterus and then close the uterus. I think whenever there is a bleeding or your incision has extended, or you are suspecting something lying posterior to the uterus, or there is a fibroid there, in those particular patients, we must exteriorize and then stitch. Otherwise, there is no need. Thank you so much.
Yes, another point is that
we are running out of time, so we will discuss.
One line comment. Whenever you are giving incision on uterus, so we have to be very sure that you have corrected the dextro rotation.
Yeah. Thank you, ma'am. And for I would like to welcome Dr. Parul Khanna, who is communicator ISOPARB Prayagraj, to take over the session and move forward.
Thank you, Dr. Amber. We now move on to our final session, which is a talk by our President ISOPARB Prayagraj, Dr. Ranjana Khanna. She will be speaking on vaginal birth after cesarean. I will now invite our chairpersons for the session. Our first chairperson is Dr. Suman Gupta, ma'am. Ma'am is Vice President, Allahabad Obs and Gynae Society. She is Executive Member of ISOPARB Prayagraj and Director and Consultant Obs and Gynae Ayushya Hospital, Prayagraj. I welcome you, ma'am. Our second chairperson for the session is Dr. Kiran Pandey, ma'am. Ma'am is Professor and HOD, GSPM Medical College, Kanpur. She is ICOG Governing Council Member, President Kanpur Menopause Society, Chairperson of IMA WDW 2019 till date. Ma'am has been awarded with various awards at national, state and district level with more than 40 awards by IMA and Rotary Club. She is also recipient of GYTI award from NIF India at Rashtrapati Bhavan. Welcome, ma'am. I now request Dr. Suman Gupta to introduce our speaker, Dr. Ranjana Khanna, ma'am.
Thank you. Thank you very much.
Thank you, Parul. Good evening, everyone. And good evening. And thanks, Amita, for giving me this opportunity to introduce Dr. Ranjana Khanna. Though it's a privilege to be doing so, but I believe Dr. Ranjana Khanna is someone who does not need any introduction. And she is our role model also. She was National Vice President FOGSI 2017. She is founder president of ISOPARB Prayagraj 2017, 2021 and 23. And she is ICOG Governing Council member, and she was president of AOGS Allahabad. Along with that, she was previously honorary secretary and treasurer also. Yeah. She was organizing chairperson of National FOGSI Conference 2017 at Delhi, organizing secretary of National FOGSI Conference Sevma Allahabad 2016. She got many national awards like FOGSI Smriti Milan Award for her work on Save the Girl Child and FOGSI Dr. D.K. Tank Award for Reproductive Healthcare Promotion Trophy. And she was faculty at various national and international conferences and webinars, and she has authored many articles and chapters in various books and journals also. She has been facilitated by many committees, and today she is going to speak on a very interesting topic, vaginal delivery after cesarean birth. And I welcome ma'am, looking forward to your valuable talk.
Thank you so much, Dr. Suman. A very good evening to all the learned faculty and the learned delegates here. My topic is vaginal birth after cesarean section. Once a cesarean, always a cesarean. Now you all can know how I got the topic of this webinar. Said Kragen in 1961. Once a cesarean, always a trial. Thorstein in 1966. Once a cesarean, always a controversy. Said Flam in 1997. WHO states that no region in the world is justified in having a cesarean rates more than 10 to 15%. But in the last 20 years, the rates of CS have risen to about 25%. The NFHS4 shows there's only 6% rates of cesarean in Nagaland and Bihar and 58% in Telangana. I think Dr. Jayam has talked about it. But what she has not talked is that Chandigarh has reported skyrocketing rate of cesarean as 98%. Options for women with previous CS include ERCS, that is elective repeat cesarean section, trial of labor after CS, that is TOLAC, and VBAC, vaginal birth after cesarean section. The National Institute of Health held a consensus developing conference on VBAC in 2010. The panel concluded that TOLAC is a reasonable birth option for many women with previous CS. The panel also found that existing practice guidelines and medical liability, which Dr. Jayam was talking about, were restricting access to TOLAC and VBAC. Now, what are the contraindications to VBAC? Hysterectomy or myomectomy involving the uterine cavity, previous history of uterine rupture, placenta previa, contracted pelvis, CPD, malpresentations, precious pregnancies, age more than 40, and obesity, BMI more than 40. The scars, I think, have been dealt in great detail, so we won't go into this. Benefits of VBAC over repeat cesarean section: early ambulation and resumption of work, economical, less chances of bleeding and infection, damage to bowel, bladder, ureter, and major vessels are avoided, devoid of anesthesia-related risks, psychological satisfaction, scar-related remote complications are avoided, and with a successful VBAC, the subsequent obstetrical career of the lady definitely improves. The fetal benefits of vaginal birth after cesarean: reduced risk of neonatal respiratory morbidity and NICU admissions. Children born vaginally have a lower incidence of asthma and pulmonary hypertension. Now, what is the criteria for selection for VBAC? Clinically adequate pelvis, period of gestation 36 to 41 weeks, expected birth weight of the baby 2.5 to 3.5 kg. That means the baby should not be very huge. Prior LSCS, which should have been low transverse, at least 18 to 24 months back. Vertex presentation, patient's willingness to take a trial after proper understanding of the risks, benefits, and success rate of VBAC. Facility to carry out immediate LSCS should be present, and there should be no associated medical obstetrical complications. Maternal risks of VBAC: 10 to 15% chance of instrumental delivery and perineal tear requiring suturing. Failed TOLAC increases maternal morbidity, 0.5% risk of uterine scar rupture, which is the most dreaded complication, 24 to 28% chance of emergency LSCS, and higher risk of blood transfusions. ERCD increases likelihood of cesarean delivery in the future pregnancies, longer hospital stay, 0.1 to 2% chance of serious surgical complications like bladder injury, increased risk of surgical complications with each subsequent cesarean due to adhesions, placenta previa, and accreta. Factors affecting the uterine scar rupture: type of previous scar, number of previous LSCS, and the healing of the uterine scar. Type: lower transverse scar, risk of rupture is 0.2 to 1.5%, low vertical scar 0.8 to 1.1%, though not much study has been done on this. Classical cesarean scar 2 to 9% risk of rupture. Number of previous LSCS: 1 LSCS 1%, 2 LSCS 3.7%. Healing of the uterine scar. Much has been said about it, but we can just in brief: uterus heals by formation of smooth muscles without fibrosis when proper suturing is done. At 3 weeks, the scar retains 30% of its final strength, and at 3 months, approximately 80% of its final strength has been regained. Incision heals by complete muscular regeneration in 80 to 90% cases. In the presence of sepsis, however, more fibrosis occurs with fewer regenerated muscle fibers, resulting in a weak scar. The factors affecting the scar integrity: there are systemic factors: age, nutrition, general condition, anemia, diabetes, obesity, ambulation, involution, and history of steroid intake. Operative technique: large amount of tissue included in each suture, poor hemostasis, unequal thickness of edges, ragged margins, eversion of endometrium, and inclusion of decidua in scar. Local factors: and because if you include decidua, I mean, initially it was the saying that the decidua will shed, subsequently causing loosening of the sutures. Local factors: location of placenta over the previous incision, devitalized uterine muscle, greatly stretched lower segment, poorly formed thick lower segment as in prematurity and transverse lie. Now, continuous interlocking technique causes a weak scar because of tissue ischemia. Suture material has already been discussed, and single versus double has been discussed. Predictors of success of VBAC: indications of previous cesarean, fetal distress, and breech placenta previa. These will give better chance of success in the subsequent cesarean. Prior vaginal delivery, 93% chances. Spontaneous labor has more success rates as compared to induction of labor. Bishop score more than 6 gives 86% success rates, interdelivery interval of more than 24 months, and previous scar thickness. Assessment of uterine scar thickness. If the lower segment scar thickness is less than 2.5 mm, incidence of rupture is 11.8%. More than 3.5, minimal risk of scar rupture. 2.5 to 3.5, monitor labor carefully. How do you know that this myometrium is inadequate for VBAC? It can show balloon-like shape of lower uterine segment, discontinuity of the uterine structure, increased echogenicity in the scar. Now, Flamm-Geiger scoring system was developed for predicting VBAC in 1997. Application of the Flamm scoring system gives fair judgment of successful VBAC. More than 5 score, incidence of vaginal delivery is more than 90%. Less than 2, incidence of Caesarean is 90%. So this is the Flamm-Geiger scoring system. Then there was this modified Dhal-Mittal scoring system, which said these are the various scores, and the score more than 6 gives a high percentage of successful vaginal deliveries. Weinstein scoring system, more the score, higher the chance of VBAC. Management, antenatal. Special antenatal care is needed. Correct dating and EDD is very important. Early detection of complications, exclude malpresentations, multiple pregnancies, and macrosomia. Ultrasound is done for fetal maturity, fetal weight, placental localization, and most importantly, scar integrity and scar thickness. In the 3rd trimester, in every visit, be very careful, take history of suprapubic pain and palpate for scar tenderness. Pelvic assessment is done after 37 weeks. Intrapartum management, admit the patient at 37 to 38 weeks. Continuous electronic fetal monitoring is done. Severe variable decelerations followed by fetal bradycardia is strongly indicative of impending rupture. Epidural anesthesia gives adequate pain relief. It does not mask the signs and symptoms of rupture. Intravenous line is maintained, blood grouping and matching is done. Orally only clear fluids are allowed, as any time the patient may have to be given a GA. Induction and augmentation of labor, mechanical methods such as Foley's catheter for cervical ripening is the best method and the safest. Oxytocin infusion is given under strict monitoring, and the dose should not be more than 20 mU per minute. Misoprostol and prostaglandin E are best avoided. Assessment of progress in labor. PV is done 4 hourly in active phase of labor and more frequently as full dilatation approaches. Cervix to dilate at least 1 centimeters per hour. Second stage not to exceed 1 hour. Partogram is to be maintained if the labor extends more than 2 hours beyond the alert line. LSCS is to be done. There should always be preparedness for an emergency LSCS, and of course, there should be an anesthetist at hand. Scar rupture and dehiscence. Scar dehiscence means disruption of part of the scar and fetal membranes are intact. Visceral peritoneum may also be intact. Bleeding is minimal. There may be a small hematoma on the scar line. Scar rupture means disruption of the entire thickness of the scar. It is associated with varying amounts of internal and external hemorrhage. Rupture. We must remember one thing, that the left end of the scar is at potential risk of rupture because the uterus is dextro-rotated and the uterine contraction pressure is centrally directed. Signs and symptoms, though we are aware, non-reassuring fetal heart racing in 50 to 70% of cases, severe variable decelerations, scar tenderness, bleeding PV, hematuria, tachycardia, hypotension, cessation of contractions. You can even feel the fetal parts superficially, and loss of presenting part on PV. Treatment is immediate resuscitation of the mother, Caesarean if dehiscence, and laparotomy if rupture. ACOG recommendations 2010 level A, women with previous 1 LSCS can be offered VBAC. Misoprostol not to be used for cervical ripening. Labor induction in a scarred uterus should not be done. It has to be done, especially don't use misoprostol. Epidural analgesia may be used. Now, these are the ACOG guidelines. and level of evidence for VBAC and TOLAC. In the absence of relevant complications, VBAC should be offered to every woman who has had one previous transverse lower segment cesarean section, level 2B evidence, multiple pregnancy, post-date pregnancy, diabetes mellitus, and suspected fetal macrosomia. They are not absolute contraindications to VBAC according to ACOG. VBAC within 18 to 24 months of a previous cesarean may be associated with an increased risk of scar rupture. Every effort should be made to confirm that a transverse lower segment incision was used. So document this fact very clearly in the documentation, in the notes. Document planned mode of delivery in the patient's notes and record the type of previous scar. Planned delivery in hospitals, of course, equipped with urgent LSCS. And induction of labor, misoprostol should be avoided, but a Foley's catheter can be considered. Prostaglandin E2 is associated with an increased risk of scar rupture, should be used rarely and with caution. Oxytocin infusion, of course, used with caution again. And continuous EFM is recommended in VBAC to detect early signs of impending rupture. Judicious use of oxytocin, suspected uterine rupture, requires urgent laparotomy. And then some good practice guidelines are there that practitioners should be aware that single-layered uterine closure may be associated with an increased risk of subsequent scar rupture. And another good practice guideline is that routine digital assessment of the uterine scar post-delivery is not beneficial, so not recommended. So to summarize, successful VBAC is a desirable outcome for mother and newborn. The pandemic of increased LSCS rates can be reduced by aiming to prevent the primary cesarean section. Hence, the first topic of this webinar was how to reduce the primary cesarean section. Thank you all so much.
Thank you, Dr. Ranjana. Wonderful presentation, so informative and exhaustive. You covered A to Z. And the last point which you said, and the first lecture which you have kept of the symposium is I think, the crux of the matter.
Yeah.
Because the best is, of course, prevention of the primary cesarean is the key probably to reduce the incidence. And actually what has happened practically, if you say, not going into the details of various factors, the factors are many with the patient, with the doctors, with the like facility, with the other supportive things. Everywhere there are reasons because of which we all know the cesarean section rate is going on increasing.
Yes.
Which we do not want, but this is what is happening. The medico-legal aspect, we all know how it is I think you all know worldwide, the maximum cases of medico-legal litigations are against the obstetricians. So naturally, everybody will like to survive first and then go ahead with anything else. So this, I mean, there are many things which you can't help it. But still, I would say the youngsters which are coming out, they are young, they are energetic, they are dynamic, they can run around, they can observe everything. So they should focus on is that judicious use of cesarean section is still important. Many a times even patient forces us. There we have to counsel very much because they also want, they will say all the time that we want a normal delivery, we want a normal delivery. But as soon as the pains will start, they will be after you, ki, madam Caesar kar dijiye, madam Caesar kar dijiye. Husband will also come, bahut pain ho raha hai, the mother-in-law will also come. I mean, you must have all faced this. So actually, lot of counseling is required so that the young girls of these days, because they have also, honestly speaking, so much used to comforts and not tolerating the pain at all. So they also need lot of counseling and the preparation into the antenatal period mentally and by physical exercise and everything. Said those they can go ahead. So that's very, very important thing. And similarly with the VBAC, or you have emphasized very rightly, it has to be the right place. You can't think of VBAC at every place. Guidelines have to be judiciously followed, and not by doctors also, but by the patient and attendants also have to understand what may happen. Anytime your decision might have to be changed. Anytime you might have to shift from the normal delivery trial to cesarean. So these are, I think if you follow the guidelines, every case is perfect for that VBAC. Still, you need lot of cooperation from the patients, from the attendants to follow your advice. Theoretically, we know good advice, we know the guidelines, doctors do follow. But what will happen when as soon as you try and the patient will start saying, no, I can't go through this. This will, ye to nahi ho jayega, wo to nahi ho jayega.
And then hanging over our heads also, na? Yes. So that's actually practically, it's really, medical college, I am in a medical college, I know we have been doing it and we can do it because hamare upar ek certain coverage and certain backup and wo hai.
But ma'am,
But I can understand how difficult
it is very difficult to do.
Yeah, how difficult it is in practice where you have a pressure of many things. So,
and we don't have the in-house facility of anesthetist also at those places, as Madam had already pointed out.
I just wanted to one more say that the facility should be with the full of all these specialists should be there. And everything should be hamara consent, jaise doctor, medical legal experts say ki our consent should be very exhaustive. So these are very, important things. Of course, theory points, everything we know, but practically it is really, really, it needs a lot of courage, it needs a lot of patience, it needs a lot of facilities, it needs a lot of monitoring and support from all aspects. Only then you can go ahead with the VBAC.
Ranjana madam, I had one doubt to ask you. This is regarding the scar thickness. You told us the thickness of the scar before taking them for the decision, like whether for VBAC or elective section and chances of a successful VBAC, etc. Is there any role or any of you do practice intrapartum ultrasound measuring the thickness of the scar, and does it matter anything? I have absolutely no idea.
No, before delivery only, before labor starts. Then only we give the trial for VBAC. Otherwise, we would not like. If it's a thin scar, we're not going to go ahead. We'll tell the patient that the scar is very thin, so it's not safe. You can rupture.
It is 4 millimeter before the delivery, and you have waited for VBAC, everything, other criteria satisfied. But in spite of that, there is no role of doing intrapartum measuring of the scar, right?
We've never done.
Okay, fine.
Ranjana ma'am, there are certain recent reviews which have highlighted that measuring scar thickness is no more relevant. It is the inter-delivery interval which is more crucial. So
yeah, that is very crucial.
Because in Delhi we are not taking scar thickness into consideration.
Okay.
If the delivery time is less
before giving a trial for before trying a TOLAC, trial of labor.
That is for sure, ma'am. But if inter-delivery period is less than 18 months, we ask them to go undergo repeat.
Yeah, actually it depends now on the time from the cesarean also.
What is your opinion?
Whom are you asking?
I'm asking you only, ma'am. Ranjana ma'am and Kiran ma'am also to kindly make the opinion. Kiran ma'am, what is your opinion?
Basically,
I think from the medical legal point of view, we should get the thickness done.
Actually, evidence-wise, if you say Dr. Anita is right, the evidence these days says that the scar thickness is not so significant. More important is the duration interval from the last cesarean. But we are also doing getting the scar thickness also done because it gives you some additional information and a little bit of extra confidence. Maybe, I don't know. I can't say, because studies also, see, Dr. Anita, there's one thing, studies are also being done by the human beings like us only. So evidence may come this, or evidence may change tomorrow. Some other bigger study may come which may say it is relevant. So what has to be done is a practical thing. Practically what can be done.
Because being ultrasonologist, I just see scar thickness is of course of importance, and the other thing where the placenta is there and how much is the gap between, how much is the vascularity, these all things are to be taken, and they give us an idea about whether this is going to be in impending rupture or not, or what is scar thickness is of course important, Anita. We are taking it.
Content placental vascularity and the other things are definitely important, but at the moment we are talking of only the scar thickness. And there I would say, though presently the studies have come like this, but still I would say ki, for a supportive or have some idea, we are doing it.
Actually, the concern was that the scar may be having different thickness at the different levels.
So there you have to take the minimal thing.
Minimal.
If something is beyond the minimum, then the cutoff line, you have to keep it in mind.
Yes, ma'am, definitely.
And at least you will never do an induction by any method.
Strength of the scar, of course.
Ma'am, we have some questions. Can we take them? Yeah. So there's a question, isthmocele observed during cesarean section, is that related to suture material like catgut or vicryl?
You are muted, Ranjana ma'am.
Oh, yeah. Actually, it is related to the suturing technique also, and the general condition and all, like I have talked about the patient. A lot depends on the whole healing capacity of the patient itself. So, suture material, well, yes, because chromic catgut is very easily absorbable. So maybe it doesn't give time to heal. Nowadays, we are not using only chromic catgut. It's ages since we've used it now.
More related to suturing technique also.
Suturing technique.
Suturing material. Both the things are important.
Yeah.
For that.
And somebody has asked about VBAC and consumer forum. So that we'll be taking up in the next part of this.
There's another question. Any evidence of uterine closure with barbed sutures during cesarean?
No.
Never. Barbed sutures you cannot use because the tissue is so thin. Sometimes the lower segment is so thin. If you will use the barbed sutures through that, it will get cut through. It's not like the post myoma cavity which you are closing.
And another thing, already we have a concern about this, that adhesion formations and all that. So in the cesarean, we can't take up for the extra this risk.
Parul, one thing is that you do not allow any even small hematoma to form in your scar when you are repairing it.
Yes.
That is very important for
that. That is very important because hemostasis has to be really well maintained.
Yeah. Then this question for Dr. Rima. If subcutaneous fat tissue layer is to be closed, which suture material to be used?
Absorbable plain catgut, not even chromic.
No. I am using either vicryl. I'm using
vicryl goes well.
Because with monocryl I am doing the subcutaneous sutures. So I just put 2 or 3 subcutaneous with monocryl itself. And 3-0 is what I'm using. So 3-0
basically using non-chromicized catgut. They say either use a chromic one or you can use even thin vicryl, as Ranjana ma'am has already.
Yes, and monocryl is very good. Anita, monocryl is very good.
Yes, Dr. Ranjana, I am also using monocryl, but at the same time, you also have to remember, do we need, like, what is the
only if you need
also?
If the layer is very thick, then
then you have to do, and you can do interrupted so that the drain.
Yes. Just 1 or 2 sutures, just 1 or 2 sutures.
Just approximation.
Just approximation.
Usually what is left from the uterine, that is what is being used. Why take a for subcutaneous tissue? I mean,
subcutaneous, because subcuticular sutures I'm using, so monocryl 3-0 I take. So if there is actually remaining bicryl, then I take it with bicryl. Otherwise, monocryl.
Then another question about peritoneal closure. Does peritoneal closure reduce adhesions? And also if there is any role of visceral peritoneal closure?
No,
no.
The evidence does not support any adhesion formation is stopped by closing any of the peritoneum. So there is studies which support it. However, individual
no.
Basically, visceral
Another thing
peritoneum,
is,
nobody
if we
is
close
closing.
the visceral peritoneum, the bladder will be advanced, more advanced in your
But
test case.
otherwise also it heals within 24 hours. The peritoneum heals spontaneously, so no need. Like
Exactly.
parietal peritoneum, obviously, I mean, there may be some variation. If personally, if you say I like to close it parietal, visceral I have not been closing for years together. I think long.
Yeah, but parietal I am also closing.
Yeah, parietal I am closing.
Then, ma'am, another question: if there is an if previous to LSCS is a contraindication for normal delivery?
No, according to ACOG, it's not a contraindication for VBAC. So ACOG is saying for VBAC, even for that. Only in India we are taking it as a absolute contraindication for normal delivery. But
not
actually. But it is
what
not.
was the indication in previous two cesarean? Whether this is
But I have seen many patients. I have seen many patients delivering normally after two cesareans.
Yes, criteria of VBAC are the same for one section or both two section, and if they are being fulfilled, you can go ahead. Depends on the. Many times the patient themselves come in the late stages, and then you have no option except to deliver them.
So maybe it depends on to case. If you will not induce a patient, if the patient has previous cesarean, but if she is already in advanced labor, why would you?
Exactly. And if she's come in full dilatation, you have nothing but she has the baby. Nothing else.
Right. Absolutely correct.
You
in most of the cases, that is the indication for VBAC.
Any last question? Any role of pelvic assessment at term?
Of course, there is a role.
Of course, it is because you
course.
see the ratio of the head coming down, head with the pelvic
37 to
dimensions.
38 weeks we must do, for seeing the cephalopelvic disproportion.
Yeah.
That's the only way to do it. Huh?
Now, that depends what question she is asking of for the primary or she is asking for a VBAC and the case.
Oh.
Because if it is a VBAC she is asking, that depends what was the indication of previous
Exactly.
cesarean. Was it for CPD or pelvic disproportion, or was it for fetal distress or something else?
Yeah.
So it all depends, like which case she's asking.
And if it is a primary, then of course we'll assess.
Yeah.
Yeah.
Any harm of using cautery during cesarean section? Does it affect healing?
No, but you have to be very choosy and selective where you are using cautery.
I normally don't like to use it in the uterine muscles.
Usually we don't use in the uterine muscle.
No.
And most of the times it is not required also.
Not required. Usually not required.
Yeah. And Kiran ma'am और Dr. Ranjana ma'am, आपको याद होगा Dr. Meena को भी जो सारे seniors हैं, they all must be remembering. There was a time when we were residents and we were working. All deliveries were vaginal deliveries unless proved otherwise. ऐसे ही होता था. And people used to accept the morbidity, mortality of the fetus with grace. They would always say, doctor tried, doctor ने बहुत कोशिश करी, ऐसा हो गया, कोई बात नहीं. They will refer the patient to nursery. They will take the baby. But अब तो कोई acceptability, negativity की है ही नहीं.
Poonam, ऐसा है, now the sword of Damascus hangs on our head, na?
Yes,
so we have to be very careful. We have to be careful.
आपने इतनी देर से कुछ भी नहीं करा पेशेंट दूसरे ने तो सिजेरियन कर दिया, बच्चा पैदा हो गया तुरंत. आप तो पेशेंट को इतनी देर से दर्द में वो झुलाए जा रही थी.
And one very important scenario, we have faced it when the patient and husband is understanding, but some new attendant will come and will try to show that he is very active and concerned. and he will make the nuisance.
Parul, vote of thanks de fatafat.
Ready with it.
Problems are more for us if it is a male baby.
Yeah, definitely. So we can't at all think of anything. No, never believe on this that they will be with us.
I know. Chalo, vote of thanks to Parul.
Yeah, very nice. I mean, Dr. Ranjana, before you give vote of thanks, congratulations. Each and every topic you selected was very, very good. And
Actually,
on my behalf also, thank you, Ranjana ma'am, and all the team for nice selection of the topic and very, very nice.
We will have a follow-up webinar for
Yes.
Definitely. I
Part
even
two.
now vote for it.
And make
Part
us a
two.
part.
रंजना मैडम ने ऐसे टॉपिक सिलेक्ट किया कि कल सुबह तक भी डिस्कस कर सकते हैं
Very, very,
Caesarean in special situations like accreta.
अभी तो 2-3 इसके parts हो सकते हैं अनीता.
Yes, yes.
Madam, complications of Caesarean sections is that
difficult extractions of the baby, medical legal
मैम
aspect.
इस पे फिर कोई एक ना वो physical 1-day conference on cesarean section करेंगे.
So it's time for vote of thanks. First and foremost, I would like to thank God for keeping us all hale and hearty. Then I thank our organizing chairperson of ISOPARB Prayagraj and founder president, Dr. Ranjana Khanna ma'am, for bringing up such wonderful topics every month for benefit of us all. I would now thank our chief guest, Dr. Anuradha Khanna ma'am, for showering her blessings, her valuable time and experts' comment throughout the webinar. I also thank our speakers for beautifully covering each and every aspect of cesarean section, beginning with primary prevention of cesarean section, wonderfully covered by Jayam Kanan ma'am, supported with statistical data. Dr. Shelley Porush Agarwal, who brushed our knowledge about various indications and contraindications for cesarean section. Dr. Anita Rajoria ma'am, who spoke about various skin and uterine incisions in different case scenarios. Dr. Rima Sarkar for her crisp talk on suturing techniques and suture materials. Dr. Shaijas P, who spoke about double versus single uterine closure and left to us and our ability for the our decision making for the technique. Dr. Ranjana Khanna ma'am for her excellent talk on vaginal birth after cesarean. And I thank our chairpersons, Dr. Meena Samant ma'am, Dr. Shubha Singh ma'am, Dr. Kanchan Sharma ma'am, Dr. Abhilasha Kumar, Dr. Usha Goenka, Dr. Rekha Rajendra Kumar, Dr. Poonam Kapoor Goyal ma'am, Dr. Kiran Pandey ma'am, and Dr. Suman Gupta ma'am for their expert comments and valuable inputs. I thank the organizing team of ISOPARB Prayagraj and Jaunpur and Kanpur Obstetrics and Gynaecology Society for bringing up such wonderful webinars, and ICOG for granting us 2 credit points. And I thank my co-conveners, Dr. Amita Tripathi, Secretary ISOPARB Prayagraj, and Dr. Ambar Khan, Secretary Jaunpur Obstetrics and Gynaecology Society for their support. Last but not the least, our academic partner, Jagsonpal Pharmaceuticals, for helping us coordinate this webinar. Thank you and a very good night to all.
Dr. Ranjana,
Thank you.
thank you.
Thank you very much. And before we leave, just a reminder of the brand names, PRORETRO.
For always being there. Thank you, Deepika.
Thank you. Bye-bye.
Good night. Stay safe and let's all meet at the ICOG.